Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections.
The UP College of Medicine Postgraduate Institute of Medicine, in partnership with the UP Medical Alumni Society, spearheaded by its Davao chapter. Welcome to the UP Grand Scientific Symposium 2021. I'm Dr. Dax Pascasio, and I will be your host for today.
Welcome to Day 2 of our Grand Scientific Symposium. We now begin with the first focus session, which will be on cardiology and gastroenterology. The chair of this session is Dr. Stephanie Marta Obilios. Dr. Obilios is a cardiology consultant in UP-PGH. Joining her as co-chair is Dr. Carrie Amiel Villanueva. Dr. Villanueva is an internist pursuing his master's in public health with data science specialization at the University of Glasgow as a UK government Chevening Scholar.
Good afternoon. Welcome to the second day of the UPCM Grand Scientific Symposium 2021. We are thrilled that you can join us for another set of high-yield sessions today. For our first session, we will be discussing two very popular and essentially interconnected topics with huge impact on Filipino lives. Hypertension is without a doubt a prevalent non-communicable disease in the Philippines. Hypertension and hypertension-related diseases are currently in the top 10 causes of Filipino mortalities. Food is the key to our health. It is a significant part of our lives, our history, and our culture. At present, international influences and diets are expanding the Filipino palate and in turn, shaping our health. To get the ball rolling, let's see what are the widespread knowledge, and if ever, common misconceptions of these two topics among Filipinos. We conducted an informal survey among non-healthcare workers. Let's hear what the Filipinos have to say.
130-80 pataas.
150-70 pataas.
Palaging mataas ang blood pressure pag kinukunan. Dalawang magkahiwalay na araw na mataas ang blood pressure pag kinukuhaan o nung kinunan sa bahay, pero normal naman kadalasan. Dalawang magkahiwalay na araw na mataas ang blood pressure sa clinic pag kinukunan sa clinic o health center, pero normal naman kadalasan. Isang beses na mataas ang blood pressure noong naglakad siya ng malayo. Gayahin ang gamot na iniinom ng kakilalang may alta presyon. Regular na check-up sa doktor o health center. Uminom ng gamot na nireseta ng doktor o health center. Kailangan mag-ehersisyo. Pwede uminom ng alak. Pwede manigarilyo. Pwede gumamit ng e-cigarette o pwede ang vaping. Pwede kumain ng maraming kanin o carbs. Pwede kumain ng maraming gulay at prutas. Pwedeng madalas kumain ng piniritong pagkain. Pwedeng kumain ng isdang sinabawan, steamed or grilled. Pwedeng madalas kumain ng karneng baka o baboy. Pwedeng madalas uminom ng soft drinks, milk tea, commercial fruit juices. Pwedeng uminom ng kape o tsaa. Pwedeng magdagdag ng asin o sawsawan gaya ng patis, toyo, bagoong sa pagkain. DASH diet, dietary approach to stop hypertension. Narinig niyo na po ba yan? Mediterranean diet. Intermittent fasting or IF. Paleo diet. keto diet? Vegetarian or vegan na diet? Maraming salamat po.
This survey had 184 respondents all over the Philippines, most of whom believe that hypertension is having blood pressure equal to or greater than 150 over 90 millimeter mercury. The next largest group, at 33%, defined hypertension as having blood pressure equal to or greater than 140 over 90 millimeter mercury. Most believe that the diagnosis of hypertension depends on having elevated blood pressures on all determinations. Only 24% believe that hypertension can be diagnosed from having 2 episodes of elevated blood pressure on separate determinations in the outpatient clinic. Most respondents know that hypertension is not just a disease for the seniors, that people younger than 60 years of age can have hypertension. Though only a little more than half know that hypertension can be an asymptomatic condition. When asked about the practices that should be observed when dealing with hypertension, the majority knows that people with hypertension shouldn't just copy their neighbor's medications. Most know that people with hypertension should see their doctors regularly. Taking doctor-prescribed medications appears to be the rule. Most believe that exercise is a must. Most believe that people with hypertension should not drink alcohol and should not smoke, nor use e-cigarettes for vaping. Most respondents also believe that people with hypertension should avoid carbohydrates, avoid fried and fatty foods, and they should take in lots of fruits and vegetables. Eating steamed or grilled fish or fish in soup is an acceptable practice for people with hypertension according to the majority. But not eating too much red meat or taking in too much sugary drinks. A little more than half believe that it is okay to drink coffee or tea. And most respondents believe that people with hypertension should not add more salt or sauces like patis, toyo, and bagoong to their food. When asked about what diet styles they've either tried or heard of, the most popular method appears to be intermittent fasting, followed by vegan or vegetarian diet, and ketogenic diet. The purpose of most of the trendy diets appear to be weight loss. But which of these diets have benefits beyond weight loss, particularly for people with hypertension? The spotlight should be placed on these diet styles as well. Through this session, we hope to pick up the tools we need to bridge the gaps in knowledge and to strengthen the widespread concepts that are scientifically sound. We just had a glimpse of what is commonly known to the Filipino people regarding hypertension and diet. Now let's discuss the science.
Our first speaker is Dr. Deborah Ignacia Ona. Dr. Ona is from UPCM class of 1998. She finished her residency in internal medicine in Philippine General Hospital. Being the first recipient of the Ida Baltasar Fellowship Grant for Hypertension, she then pursued a clinical and research fellowship at the Boston University College of Medicine. Recently, she received her master's degree in business administration from the Maastricht School of Management in the Netherlands. Dr. Ona is the incumbent president of the Philippine Society of Hypertension. She is currently an associate professor and the assistant chair for postgraduate training and service of the Department of Medicine in UPPGH. She is also the vice president and assistant chief medical officer of St. Luke's Medical Center, both in Quezon City and Global City. Let us all welcome Dr. Deborah Ignacia Ona.
Good day, everyone. Thank you for the invitation and thank you for the generous introduction. I'm here to talk hypertension under pressure, looking into the 2020 Philippine Guidelines for the Management of Hypertension. Why is hypertension important? According to the Global Burden of Disease in 2019, 10.8 million deaths are caused by high blood pressure. That translates to 300,000 deaths per day. If you look at the leading causes of mortality in the Philippines, you see that the top 10 causes of diseases are hypertension and hypertension-related diseases such as ischemic heart disease, cerebrovascular disease, and hypertensive diseases. So much so that if you look at the interstroke and interheart study, the number one modifiable risk factor for stroke is hypertension, and the number four modifiable risk factor for heart attack is hypertension. If you look at the projected number of deaths due to hypertension in the Philippines from 2015 to 2050, you see that hypertension and hypertension-related deaths almost double in a span of 25 to 30 years. And if you look at the Philippine Registry of Hypertension Prevalence from 1992 to 2017, you see that the prevalence of hypertension is increasing, whether it's a nationwide survey by FNRI, whether it's the Pression study by the Philippine Heart Association, or the May Measurement Month, which is a screening initiative spearheaded by the International Society of Hypertension, together with the Philippine Society of Hypertension. And if we zero in the Philippine data, that May Measurement Month in 2017, out of the 268,490 screened individuals, 34% were hypertensives. Out of the 34%, 86% were on medications. But what is alarming is that out of those who were given medications, only 58% have their hypertension under control. This is alarming as we have around 42% of individuals walking around with uncontrolled BP, waiting for complications to set in. This is better illustrated in the Pression study, wherein they look at control rates of hypertension from 1991. And as our control rates increased from 10% to 37%, our uncontrolled rates basically decreased, but the big part of the pie are still patients with uncontrolled hypertension. As I have said, these patients are walking around and are like walking time bombs. So what are the characteristics of hypertension among Asians? We know that stroke is more common than coronary artery disease. There's a steeper association between blood pressure and stroke. There's a high salt intake with high salt sensitivity. And because of the advent of fast food, there's an epidemic of obesity and metabolic syndrome. We also have a prevalence of non-dippers, which is high. So when you do a 24-hour ambulatory BP monitoring, you see that the blood pressure of those patients don't go down when they are asleep. They say that for non-dippers, they are associated with increased cardiovascular risk. So it is important to have 24-hour blood pressure control. So given this scenario wherein we have an increasing prevalence of hypertension and with dismal control rates, the Philippine Society of Hypertension, together with the Philippine Heart Association, came up with 2020 clinical practice guidelines for the management of hypertension in the Philippines. So these are the steering members together with the technical review committee, the people who are responsible for the guidelines. So it was spearheaded by the two societies in collaboration with experts from various fields. We actually did the adaptive process, which is an efficient, cost-effective, and evidence-based method of making guidelines. It customizes or modifies existing guideline recommendations to suit the local context and add any local flavor or researches or new information on the clinical question. So it uses multiple guidelines that have been published and their content to come up with a new set of guidelines that are locally relevant. The steering committee nominated a group of experts from the different specialty societies that will comprise the technical working group. So the technical working group was organized into 6 clusters that developed 6 areas covered by the CPG. So we have general recommendations for the adult population, persons with diabetes, persons with CKD, stroke, hypertension among pregnant women, and pediatric population. For this talk, I will zero in on the recommendations for adults with hypertension. So this is the process of guideline development. So that the working groups came up with 30 clinical questions that are usually ask in practice. So what the working groups did was to do a literature search, and from that literature search, they came up with recommendations to answer the clinical questions. Once the recommendations were done, these were then presented to the panel of experts, and this was discussed and approved by consensus through the panel of experts. The recommendations were then subjected to a public fora through webinars wherein feedback from all stakeholders were taken into consideration. So the recommendations that I will present today regarding the adult population is a result of these iterative processes. The first clinical question that we usually ask is, what is the definition of hypertension? So among adult Filipinos, 19 years old and above, we defined hypertension as a blood pressure of 140/90 or above, typically at least twice taken on 2 separate days. So this guideline defines hypertension as an office BP of 140/90 or above, taken in accordance with the proper standard BP measurement. A cutoff value has been set to simplify the diagnosis of hypertension and to rationalize the treatment decisions surrounding it. Hypertension is defined here as the level of blood pressure at which the benefit of pharmacologic treatment supported by lifestyle interventions far outweigh the risks and costs of treatment as documented by clinical studies. So the Philippine recommendation opted to make it simple, and the definition of hypertension remains unchanged from the 2011 guidelines because there is no compelling reason for that change. Also, national surveys and prevalence studies done in the Philippines use the same definition of hypertension, and maintaining the same criteria would avoid confusion in disease surveillance. It is also recommended that blood pressure be classified as normal, borderline, and hypertension. So out-of-office BP measurements are recommended as useful adjuncts in the diagnosis of hypertension, with ambulatory blood pressure monitoring as the preferred method and home blood pressure monitoring as an acceptable alternative. So this is the definition of hypertension from normal, borderline, and hypertension. What about out of office BP measurement? So home BP monitoring is done by recording 3 consecutive measurements at least 1 minute apart and with the person seated. The BP is recorded twice daily, ideally in the morning and in the evening. The BP recording continues for at least 4 days to a week. Discard the measurements taken on the first day and use the average value of all the remaining measurements to confirm the diagnosis of hypertension. ABPM, on the other hand, ensures that at least 2 measurements per hour are taken during the patient's usual waking hours. It uses the average value of at least 14 measurements taken during the patient's usual waking hours to confirm the diagnosis of hypertension. So the second question, what device is recommended for accurate blood pressure determination and monitoring? So we said that a properly validated digital device is recommended for in-office or out-of-office use. We recognize that the Android sphygmomanometer is widely used and cheap and is accessible in all areas of the Philippines. It can be used in office or out of office, provided that proper training and the device is periodically checked according to standard maintenance procedures. The Android sphygmomanometer is recommended for special cases like the presence of arrhythmias or extremes in blood pressure levels. So how do we do proper blood pressure measurement using the digital BP apparatus? So the back should be supported with the feet flat on the floor. The cuff should fit the arm size. So we have to have different cuff sizes. We should do electronic upper arm cuff or manual auscultatory should be validated, and there should be no talking during and in between measurements. The patient should be in the quiet room, comfortable temperature. The patient should have not smoked, drank coffee or any caffeinated drinks, exercised for the past 30 minutes. The bladder should be empty. The patient should be relaxed for 3 to 5 minutes. So we take 3 measurements at 1 minute interval and use the average of the last 2 measurements. The third question, basically, what are the blood pressure thresholds for treatment and the general BP targets for the prevention of cardiovascular disease? So all guidelines that we've looked at agree that patients with hypertension should receive antihypertensive treatment on top of diet and lifestyle modification to reduce blood pressure to treatment targets. Lowering blood pressure to less than 140/90 has been shown repeatedly to reduce morbidity and mortality. This local guideline will take a practical approach to BP targets in recommending a threshold of greater than 140/90 to start therapy. This can be addressed with diet and lifestyle modification alone in low-risk hypertensives or concomitant lifestyle changes with medical treatment in high-risk individuals. We recommend these interventions to achieve a blood pressure of less than 130/80 in Filipino hypertensive individuals. For the very elderly, defined as 80 years old and above, a therapeutic threshold of 150/90 millimeter mercury to achieve a goal BP of less than 140/90 is recommended. So we all know that risk factor stratification is done to stratify hypertensive patients since the presence of one or more additional cardiovascular risk factors proportionally increases the risk of coronary, cerebrovascular, and renal diseases. Risk stratification also directs the degree of aggressiveness in setting BP targets and in using pharmacologic treatment on top of diet and lifestyle modification. So risk stratification involves identification of risk factors, presence of hypertension-mediated organ damage, and established cardiovascular and related diseases. So these are the risk factors associated with hypertension: age, gender, body weight, diabetes and dyslipidemia, a family history of cardiovascular disease or hypertension, early onset menopause, smoking, psychosocial or socioeconomic factors such as poverty. Presence of HMOD or hypertension-mediated organ damage would be LVH with ECG, CKD, moderate to severe, or any other available measure of organ damage. And as we all know, established cardiovascular disease such as CHD, heart failure, stroke, peripheral vascular disease, atrial fibrillation, and CKD. So a complete history and physical examination are warranted and can provide the physician clinical clues in diagnosing hypertension and identification of hypertension-mediated organ damage. It can also help in detecting secondary forms of hypertension. A simple fundoscopy can be utilized to check for eye grounds. The physician can also order the following diagnostic tests to assess and confirm the suspicion of hypertension-mediated organ damage, coexisting diseases, or secondary hypertension. This would include complete blood count, serum electrolytes such as sodium, potassium, creatinine, and BUN to estimate your GFR, fasting glucose, and lipid profile for concomitant diseases. It is also important to check for albuminuria and to check for LVH as well as atherosclerosis or stenosis. The fourth clinical question, which is the last question for the adult recommendations, would be among Filipinos with hypertension, what are the general treatment recommendations? 4.1 looks at non-pharmacologic approaches for persons with hypertension. So basically, we know that lifestyle modification remains the cornerstone for the management of hypertension. So robust clinical trial evidence have been shown that it can prevent or delay the onset of high blood pressure and can reduce cardiovascular risk. Healthy lifestyle choices are the first line of antihypertensive treatment and can also enrich the effects of antihypertensive treatment. So lifestyle modification should include the following: sodium restriction for patients with prehypertension or hypertension to as low as 1,500 milligrams per day. For individuals that are healthy, it's about 2,300 milligrams per day or roughly a half a teaspoon of table salt. The DASH diet which is low in sodium and high in dietary potassium, can be recommended for all patients with hypertension without renal insufficiency. Aerobic physical activity and dynamic resistance exercises are also recommended around 150 minutes per week. Abstinence for alcohol or moderate alcohol intake, and significant weight loss of more than 5% of baseline weight for those who are overweight and obese. If you look at the BP reduction for these non-pharmacologic approaches, you see that if you combine all of the non-pharmacologic approaches, it affect the blood pressure reduction effect of 1 to 2 drugs, basically. So for 4.2, it actually talks about the drugs for the treatment of hypertension among adult Filipinos for the prevention of cardiovascular disease. On the evidence of large-scale clinical trials, ACE inhibitors, ARBs, calcium channel blockers, and diuretics, thiazide and thiazide-like diuretics, are selected as the first-line drugs. Overall, major cardiovascular outcomes and mortality were similar with treatment based on initial therapy with all of the 5 major classes of treatment. All 5 major line drug classes can be combined with one another, except that for ACE and ARBs and RAS blockers with direct renin inhibitors. The combination of ACE inhibitors or ARBs with a CCB, with either a CCB or a thiazide-like diuretic, are complementary because both CCBs or diuretics activate your RAS and will also limit the adverse effects associated with diuretic or CCB monotherapy. The choice for starting on initial combination therapy results in greater achievement of BP lowering at the shortest amount of time. So we want to be able to achieve the blood pressure goal at the shortest amount of time. So low-dose combination therapy has been shown to be more effective than maximal dose monotherapy. For areas wherein the single pill combination therapy is not available or not affordable, we recommend the use of free combinations, keeping in mind that we need to bring down the blood pressure to our goal BP. Beta blockers can be given as initial therapy in hypertensive patients with coronary artery disease, acute coronary syndrome, high sympathetic drive, and pregnant women. So this is just a guide. If your patients have a blood pressure of more than 150/100 in adult patients or more than 160/100 in the elderly, we need to start those patients with 2 agents, a RAS inhibitor plus a CCB or a diuretic, basically. So this is a simple algorithm that we've actually done. So for adults with blood pressure of more than or equal to 140/90, you institute lifestyle changes. And then the next question that you ask yourself, does that patient have hypertension-mediated organ damage? That patient has cardiovascular disease or is cardiovascular risk equivalent, or if that patient is high risk. If the answer to that question is no, then if the BP targets are achieved after 3 months, then you just maintain the lifestyle change. If the answer to that question is you haven't achieved BP targets, then you choose any of the first-line drugs as monotherapy or in combination, whether it's a RAS blocker, a CCB, or a thiazide diuretic. If that patient is very high risk, has hypertension-mediated organ damage, you institute as soon as possible pharmacologic therapy with any of the first-line drugs. If the BP targets are achieved after 3 months, you just maintain the medications and monitor the blood pressure. If the BP targets are not achieved, if that patient is on monotherapy, add a second agent from the first-line drugs. If that patient is already on 2 drugs, add another drug from the first-line choices. If the BP targets are achieved on combination drugs, then you maintain medications and monitor the blood pressure. If the BP targets are not achieved on combination drugs, then you need to refer that patient. So what are the preferred combinations? As we've said, it's a RAS blocker plus a CCB, a RAS blocker plus a thiazide or thiazide-like diuretics. So beta blockers may be used as initial therapy in hypertensive patients with coronary artery disease, acute coronary syndrome, high sympathetic drive, and pregnant women. So if you have patients who continue to be uncontrolled on 3 drugs, maximum dose, one of which is a diuretic, they're considered to be resistant hypertension and may warrant referral to specialists for workup or initiation of second-line agents. What are these second-line agents? Your mineralocorticoid inhibitor, your spironolactone or eplerenone, your alpha blockers, or your centrally acting drugs. So in summary, for the adult population, our BP therapeutic threshold wherein we initiate lifestyle modification and pharmacologic treatment would be a blood pressure of more than or equal to 140/90 with a blood pressure goal of less than 130/80. For the elderly, our BP therapeutic threshold would be a blood pressure of more than or equal to 150/90 with a blood pressure goal of less than 140/90. I hope that you learned a lot from our guidelines. We just need to remind you that guidelines are there to guide you with the management of hypertension. It is important that you individualize treatment for every patient that you see. So I invite you, if you want to get hold of the executive summary of the 2020 Philippine Guidelines for the Management of Hypertension, it's open access. You just Google it so that you can download the manuscript. So I'd like to thank everybody for listening, and I hope that you stay safe. Good day.
Thank you, Dr. Ana. Our next speaker is Dr. Patricia Ann Cabral Prodigalidad. Dr. Cabral Prodigalidad is from UPCM class of 1999. She completed both her internal medicine residency and gastroenterology fellowship at the Philippine General Hospital. She is currently a clinical associate professor at the UPPGH Department of Medicine and an active GI consultant at St. Luke's Medical Center Global City, Makati Medical Center, and Asian Hospital and Medical Center. Please welcome Dr. Patricia Ann Cabral Prodigalidad.
Good afternoon, everyone. Today, I was tasked to talk about 2 special diets that have proven themselves highly effective against hypertension and cardiovascular disease. I'm grateful for this invitation and would like to thank the organizers for this opportunity to speak before all of you. The objectives for today will be to discuss the basic components of DASH and Mediterranean-style diets, to review the data behind the DASH and Mediterranean-style diets, and describe their benefit related to hypertension and cardiovascular disease. The global burden of cardiovascular disease and hypertension have substantially decreased worldwide, yet they are still the leading causes of death and disability. Hypertension, as we all know, influences adversely cardiovascular events as well as renal outcomes. Both cardiovascular disease and hypertension result in complex interactions between genetics and environmental factors. Current management guidelines recommend, as an integral part of treatment, the adoption of certain lifestyle modifications, such as the reduction in salt, weight loss, the decrease in alcohol, and appropriate diet. Since dietary associated risk is the most important behavioral factor influencing global health, it appears the best target in the challenge against hypertension and cardiovascular disease. The DASH and Mediterranean diets are perhaps the 2 most popular and best studied diet approaches to hypertension and cardiovascular disease. And we will spend most of our time talking about them so that hopefully in the end, we can confidently prescribe them to our patients. There is growing evidence that, of course, with a few exceptions, single nutrients have effects of limited magnitude on chronic disease compared with whole foods or foods with complex integrated dietary interventions. Okay. Before DASH, the non-drug options were reduction in salt, weight loss, and moderation in alcohol. And these were difficult because we know that 95% of patients who lose weight simply regain all the weight back within 5 years. And we also know that with the prevalence of processed foods, it's difficult to stay away from salt with your daily diet or your daily life. And the prevailing wisdom was that individual nutrients were responsible for lowering blood pressure. The candidate nutrients were calcium, magnesium, and potassium. But we later found out that these nutrients were found to only reduce blood pressure minimally. So the DASH trial, which was organized by the US National Heart, Lung, and Blood Institute, looked at just how whole diets affects hypertension and blood pressure control. The study included over 450 participants who had no more than 160 millimeters mercury of systolic blood pressure and no more than 95 millimeters mercury for diastolic blood pressure. About 27% of them had hypertension, more than 50 or about 50 were women, or 50% were women, and 60% were African Americans. And they were randomized to either a typical American diet, which was the control, or the American diet with fruits and vegetables, or the combination diet, which is what we now call the DASH diet. So the typical American diet was somewhat lower in potassium, magnesium, and calcium. It was also low in protein at about 15%. The American diet with fruits and vegetables also was low in potassium, magnesium, and calcium, also did have a 15% protein content, but there was plenty of fruit and vegetables included. In the DASH diet, there was plenty of fruits and vegetables, low-fat dairy products, poultry, fish, and nuts. It was low in fat, sweets, and sugar-containing beverages, and it was low in red meat. But because of how it was composed or the makeup of their diet, it was high in calcium, high in magnesium and potassium and fiber, and low in saturated fat and cholesterol. It had a higher protein content at 18%. So this was an 11-week study where all 3 plants included about 3,000 milligrams of sodium daily. And the study participants were given about 500 milligrams of discretionary sodium. Alcohol intake was also limited to 2 drinks or less per day. This is a typical 2,000 calorie per day eating plan. You see the appropriate amount of daily servings on each of the nutrient components. And all of these also have with them the significance listed in the last column. To the right, you see the diet is low in saturated fat and higher in protein than the typical American diet. So what were the results of the DASH trial and what did we learn from it? Well, we learned that the DASH diet lowered systolic blood pressure by about 6 millimeters mercury and the diastolic blood pressure by about 3 millimeters mercury on average for all patients who were on the DASH diet. But for those with stage 1 hypertension in particular, the DASH diet reduced systolic blood pressure by about 11 millimeters mercury and diastolic blood pressure by about 6 millimeters mercury. What's amazing is that the reduction happened within 2 weeks of starting the diet. And this prompted the 1997 JNC or JNC6 to recommend the DASH diet to aid in BP control. The American diet with fruits and vegetables also revealed or showed a lowering of blood pressure, but less so at 3 millimeters mercury systolic blood pressure and 2 millimeters mercury diastolic blood pressure. With regards to lipids, the total cholesterol and LDL and even HDL concentrations were lowered down. However, there was no significant effect on triglycerides. There was a net decrease in total and LDL cholesterol in men more than women, and there was no significant difference by race or baseline lipid concentrations, except for the HDL, which decreased more in those with higher baseline HDL cholesterol concentrations. A few years later, the investigators decided to look at the effect of sodium and whether or not the combination of DASH and lowered sodium would produce even better blood pressure lowering. All three diet plans in the original DASH study contained 3,000 milligrams of sodium. This is roughly 20% below the US average for adults, but still above the RDI of 2,400 milligrams per day. So building on the DASH study, the investigators designed the DASH sodium study, which is a randomized crossover study where participants received 3,000 milligrams, 2,400 milligrams, and 1,500 milligrams of salt in random order over 30 days. So what were the results? Well, they found that the DASH diet lowered blood pressure at all levels of sodium intake. There was a lowering of sodium, or the lowering of sodium to 2,400 milligrams per day effectively reduced blood pressure for all. And if you lowered sodium further to 1,500 milligrams per day, this would reduce blood pressure by as much as 2 times. In particular, for non-hypertensives on controlled diet, it reduced blood pressure by about 5.6 over 2.8 millimeters mercury on average, and on the DASH diet by 1.7 over 1.1 millimeters mercury. But most notable and most important to note is that the combined effect of DASH plus the lowered sodium at 1,500 milligrams per day lowered blood pressure significantly by about 8.9 millimeters mercury systolic and 4.5 millimeters mercury diastolic. So if you look at this table on the right side, which is taken from the Veterans Affairs Cooperative Study, looking at 6 different types of antihypertensives and how they affect or lower blood pressure in stage 1 hypertensive patients, it appears that diet, or at least the diet of DASH plus the lowered sodium, lowers blood pressure as much as the drugs do. So this is something that we need to consider when we are managing our patients with hypertension. There was so much information to be gained from the DASH and the DASH with lowered sodium trials that the investigators thought maybe these benefits of these dietary patterns extend beyond hypertension alone. Since there was convincing evidence that the DASH and its low sodium variant produced a greater BP lowering, the investigators then asked, will this lowering of blood pressure with the low sodium diet or the DASH diet or the combination of both still improve cardiovascular outcomes? We know that cardiac strain, injury, and inflammation may trigger cardiovascular events, and the investigators deemed it appropriate to study the respective cardiac markers. So they looked at the biomarkers in the stored specimens of these patients. They took the high sensitivity troponin I for cardiac injury, the NT-proBNP for cardiac strain, and the high sensitivity CRP for inflammation. And these were the findings: that DASH, or the DASH diet, lowered subclinical cardiac injury and inflammation, but had no significant effect on cardiac strain. The reduced sodium diet lowered subclinical cardiac strain, but still increased inflammation in these patients. And the thought was that the DASH diet effect had not been there anymore, so that inflammation was predominant. But again, most importantly, the combined DASH and reduced sodium diet lowered subclinical injury and cardiac strain significantly, while not inducing inflammation. So again, another plus for the DASH diet. That simply underscored the hypothesis that the DASH diet can potentially improve cardiac outcome. In the 1970s, an American biologist by the name of Ansel Keys published the preliminary results of the 7-country studies. This showed that the populations dwelling on the shores of the Mediterranean Sea in Greece, southern Italy, and the former Yugoslavia had lower incidence of coronary artery disease and cardiovascular disease in general. So the study later revealed, or the 15-year mortality rate was substantially lower than in Northern Europe and the United States. And this finding was hypothesized to be due to the dietary habits of these populations, where the regions with the highest cardiovascular disease mortality also had greater saturated fat intake and higher serum cholesterol levels. The Mediterranean diet, as was initially described by Keys himself, is a diet that's rich in whole grains, fruits and vegetables, low in meat, and with a considerable amount of fat derived from olive oil and nuts. But this cartoon that I'm presenting is the modern-day Mediterranean diet pyramid, which also takes into account the frequency by which all the nutrients are consumed and the importance of regular physical activity. You'll note the abundance of plant foods, cereals, whole grain breads, beans, nuts, and seeds, fresh, seasonal, unprocessed foods, large quantities of fruit, low quantities of concentrated sugars or honey, and olive oil still as a main source of fat, low to moderate amounts of cheese and yogurt, and low quantities of red meat and higher quantities of fish. There also is a low to moderate amount of red wine. So generally, the Mediterranean diet is a diet that is moderate in total fat. It's relatively low in saturated fat. It's high in fiber at 27 to 37 grams per day, high in monounsaturated and polyunsaturated fatty acid, and it places, again, emphasis on omega-3 fatty acids. Many different studies were subsequently published looking at the benefits of the Mediterranean diet. And one of the more important ones to mention is this study on the relationship between adherence to the Mediterranean diet and survival. This study, involving over 22,000 Greeks enrolled in the EPIC trial with a median follow-up of 44 months, showed that a higher adherence to the Mediterranean diet was associated with an increased overall survival. They noted a 25% rise in the survival rate for every 2 points increase in the Mediterranean diet score, which was assessed at baseline. The association with the med score was also evident for mortality from coronary artery disease. And interestingly, no association emerged between mortality and each of the foods considered in the Mediterranean diet score, which again indicates that the total effect of the whole dietary regimen was stronger than any of the effects of its individual components. There were many epidemiologic prospective studies comparing cardiovascular outcomes and adherence to the Mediterranean diet. And these were all assessed through food frequency questionnaires. But due to the lack of data and because of the lack of data from large randomized intervention trials, the evidence supporting the Mediterranean diet for primary prevention of coronary artery disease was not enough, not solid enough at least, to deserve a strong recommendation by the cardiovascular guidelines. So finally, in 2013, stronger evidence supporting the Mediterranean diet for primary prevention of coronary artery disease came from the PREDIMED trial. From 2003 to 2006, over 7,000 Spanish adults with high cardiovascular risk, but with no definite diagnosis of cardiovascular disease, were randomized in a 1:1:1 ratio to one of the three study diets: a Mediterranean diet supplemented with extra virgin olive oil, a Mediterranean diet supplemented with mixed nuts, or the control diet, which was a low-fat diet. The primary endpoint event occurred in 288 participants, and stroke was the most significantly reduced event with the Mediterranean diet, followed by myocardial infarction. The total mortality showed a non-significant trend towards the control, towards a reduction in Mediterranean diet groups compared with the control group. However, in the intention to treat analysis, the hazard ratios were significant at 0.69 for the extra virgin olive oil Mediterranean diet group and 0.72 for the Mediterranean diet group with nuts. or supplemented with nuts. So again, in this trial, the authors were able to conclude that the incidence of major cardiovascular events was lower among those assigned to a Mediterranean diet supplemented with extra virgin olive oil or nuts than among those assigned to a reduced fat diet. The 30% reduction of cardiovascular events seen with a Mediterranean diet in the Prediment trial is still truly remarkable and strengthens the evidence in favor of recommending the Mediterranean diet for the primary prevention of coronary artery disease. But how does the Mediterranean diet influence hypertension? So in this paper by Estefania and group, the investigators looked at the blood pressures of the same study participants of the Prediment trial. They noted the blood pressures at baseline and every year for 4 years. And they found that the percentage of participants with controlled BP increased in all groups, and particularly for the Mediterranean diet groups, there was a significant lowering of diastolic blood pressure versus the control group. So then the authors concluded that both Mediterranean diet and low-fat diet exert beneficial effects on blood pressure and could be part of the advice to patients for lowering their blood pressure. And that diastolic blood pressure could be made even lower with a Mediterranean diet. On the secondary prevention of coronary artery disease, the Lion-Heart study was a landmark study that tested for secondary prevention of coronary artery disease with the Mediterranean diet from 1988 to 1992. They had 605 survivors of a first MI enrolled and randomized to either dietary advice on low-fat diet or an hour-long educational session on the Mediterranean diet supplemented with canola oil. At the mean follow-up of 27 months, they found a significant reduction in deaths for the Mediterranean diet compared with the control group. And at the end of the study, at 46 months, a reduction in cardiovascular mortality was found to be greater with a hazard ratio of 0.35 and a total mortality hazard ratio at 0.44. What about atherosclerosis progression? The CardioPrev study, or the coronary diet intervention with olive oil and cardiovascular prevention, is an ongoing prospective randomized trial looking at about 1,000 coronary heart disease patients. And the primary objective was to compare the effect of two healthy diet approaches, the low-fat, rich in complex carbohydrates diet versus the Mediterranean diet, rich in extra virgin olive oil. In this report on the secondary outcome, that is atherosclerosis progression, the intima media thickness of both common carotid arteries was ultrasonically assessed. The intima media thickness is known and is validated as a surrogate for current status and possible future cardiovascular disease risk. The analysis showed that the intima media thickness is reduced significantly with the Mediterranean diet. And there was the same reduction or improvement noted for carotid plaques. The same could not be said for the low-fat diet. So definitely, again, another plus this time for the Mediterranean diet. In summary, both the DASH diet and the Mediterranean diet should be considered as adjunct treatments for our patients, depending on their health profile and needs. So while the DASH diet places no emphasis on oily fish as the Mediterranean diet does, the Mediterranean diet places no emphasis on sodium restriction as the DASH diet does, they both emphasize the need for plenty of fiber, fruits and vegetables, whole grains and nuts, low-fat dairy and lean protein. They also both consider the importance of decreased saturated fat and refined grains and added sugars. And they also both recommend moderate or no alcohol consumption at all. And finally, knowing all of the things that we talked about, a one-size-fits-all nutritional intervention may still be a limited approach in patients with cardiovascular disease and hypertension. Dietary requirements of patients differ not only because of our goals for them for primary and secondary prevention of cardiovascular disease or hypertension, but they vary also because of the differences between individuals. We need to look at individual factors such as genetics and their cultural habits, their comorbidities, and their risk for disease. And hopefully, by considering all of these, we are able to tailor dietary intervention appropriately. Thank you very much. I'll be happy to.
Thank you, Dr. Cabral Podigalidad. Now we proceed to the open forum. The question and answer portion will be moderated by Dr. John Anunuevo and Dr. Christian James Nazareth. Dr. John Anunuevo is a renowned cardiologist and has held numerous eminent positions in many prestigious hospitals, societies, and associations. He is the current chair of the UPPGH Department of Medicine. Being the chair of the hospital's largest clinical department, he is at the forefront of the hospital's COVID-19 response. Joining Dr. Anunuevo is Dr. Christian James Nazareth. Dr. Nazareth is currently the medical officer of Santa Monica District Hospital and Del Carmen District Hospital in Surigao del Norte. He works as part of the DOH Caraga's pilot referral system in Siargao Island, patterned after the Cuban Polyclinic model. Dr. James Nazareth is also the founder and CEO of Island Care Unit, an enterprise set to develop social, business, and health innovations in the island.
Good afternoon, everyone, and hello, James, my co-moderator. Before anything else, we would like to thank our two excellent speakers for those very informative lectures. And James, since we have a very limited time, let's go ahead and probably you can ask the first question, James.
Okay. Good afternoon, Dr. Ona. So this first question is from our audience. The first question is, what is your recommendation for those patients with anxiety-induced or white coat hypertension, increase in blood pressure, taking beta blockers as needed?
Basically, thank you for that question. That's a very relevant question because we have a lot of patients right now who are very anxious because of the pandemic. That's why we recommended actually home blood pressure, out-of-office blood pressure monitoring so that we know if that patient really has hypertension or not. So the recommendation is to check their blood pressure, one in the morning, one in the evening. If they're using a digital monitor, it has to be on the same side where their provider actually took their blood pressure. So if it's on the right side, it has to be on the right side. If it's on the left side, it has to be on the left side. So you have three questions. Anxiety first. So it's a common cause of hypertension. Secondary. It's a common cause of secondary hypertension. So if patients are anxious, we always tell them to do activities that can lessen their anxiety. Basically, when you have that conversation with that patient, when you educate them on their hypertension, like you have to tell them that they have to monitor their blood pressure and it has to be more than 140/90 all the time, then that's the time that you need to give them medications. But you have to talk to them. I know we're very busy practitioners, and ask them what they're anxious about and try to go through them what can reduce the anxiety. So basically, if they can't, then we give them anxiolytics if they cannot do it. But we don't usually give beta blockers because, especially if they're not really hypertensive, because that can give you a lot of problems. If they stop the beta blocker, baka magkaroon pa ng hypertension, basically. So those are the things. For white coat hypertension, we tell them you have to educate them as well. If there are modifiable risk factors that they can modify, as Sandy was saying, if they are obese, if they're drinking, if they're smoking, if
if they're drinking alcohol, if they don't exercise, if they're not drinking healthy, especially if they have a strong family history. They say there's a study that says that these patients with white coat hypertension might develop hypertension in the future if they have the non-modifiable risk factor. So at this early on, again, we need to educate. I think the key here is to educating each patient, especially those who are hypertensive, because they have a lot of things on their mind. So to modify the modifiable risk factors, but the be all and end all is how they have to really know how to measure their blood pressure and try to see if their blood pressure is consistently 140/90, then they are hypertensive. They need to see a doctor. If there are other causes of hypertension, then they need to have that conversation with the doctor to help them manage the all of the things that can cause the increase in the blood pressure.
Thank you, Debbie. Thank you very much. Sandy, you've talked about two important forms of diet, the DASH and the Mediterranean. But I'm sure all our listeners have been introduced to a lot of other forms of diet. So can you tell us if there are any references or media platforms or even YouTube videos that our listeners can look into so that they will probably be educated more with respect to healthy eating?
Hi, sir. Thank you for that question. Actually, the internet and the web is just full of information. You just need to type it and Google it all, and then it will come out. You just need to be really careful about what you look at. For the DASH diet in particular, you want to look at the US NIH, National Heart, Lung, and Blood Institute, which was the sponsor really of the DASH trials. And they explain very well in very easy to understand and very simple terms how to best approach the DASH diet and how to get started on it and how to maintain yourself on it without falling off the wagon, I guess you could say. So that would be my primary source if I were interested in doing the DASH diet. Especially if I had problems with hypertension, because they really are just so good at explaining it in very simple terms, and you really feel like it's easy to do. It'll motivate you to do the DASH diet. For the Mediterranean diet, I don't think there is a website or a particular source that you need to go to, but you just type in Mediterranean diet and it's all there, right? You'll see so many articles and even videos advising and coaching about the diet. You'll see an unlimited number of recipes that you can try, and they're not very difficult recipes to do, because what's good about the DASH diet and the Mediterranean diet is, the ingredients are very easy to find. They're common ingredients that you can use even in, the typical Filipino fashion, typical Filipino meal. So that's for the DASH and the Mediterranean diet. For, keto diet and all the other diets, I have to admit, I'm not the most familiar with them. I'm not the expert, but I'm pretty sure they will be there. Again, I just want to caution people when they're looking at these things, or if they're trying to consider these diets. I don't know if you really were truly looking at maybe diets that'll help you in terms of hypertension and cardiovascular disease, then you shouldn't look beyond the DASH and Mediterranean diet anymore. But I guess if you talk about weight loss, that's something else. There's some weight loss with DASH and Mediterranean diet, maybe not as much as what's supposedly promised by the, I dare say, fad diets, right? But if you really want to study the other diets, like the keto diet or the intermittent fasting or the paleo or paleo diet, you can it's everywhere. It's on the net. So I wish I could point you to a source that's reliable for those types of diets. Unfortunately, I'm not able to.
Thank you, Sandy. James?
Yes, follow up on that question po, ma'am. Dr. Cabral Prodigalidad, sorry. Like for example, me, I'm a primary care physician, so I take care of families of patients. No? So how can I advise them as a doctor to convert? Because you said there's the 1,500 milligrams salt and the 2,400. How can I advise them in that typical setting of a Filipino family kitchen, like how can I advise them the amount in terms of the amount of salt intake?
Fortunately, there are calculators, right, and tables that you can look up on the net as well, right? Everything is there, but maybe simply for you to, if you want to convert, because we're talking about milligrams of sodium, right? So, and the DASH diet and the DASH plus lower sodium diet says that you need to be on 2,300 milligrams of sodium, and the other one is saying that you want to be on 1,500 milligrams of sodium. So a teaspoon of salt is about 2,300 milligrams of sodium. It's that little, unfortunately. If you were to talk about, I wish I was able to incorporate this into my lecture because it's very interesting, but I did look it up. And thankfully I did, because you were going to ask that question. Patis or fish sauce, a tablespoon of patis or fish sauce would be about 1,400 milligrams of sodium. So there it is. And even bagong alamang is there, right? That would be about, for a tablespoon, also about 550 milligrams of sodium. And you would have for maybe a tablespoon of soy sauce around 900 milligrams of sodium. So generally, I think the number that you're supposed to remember is 2,300, and that's a tablespoon of salt. And then 1,400, 1,500 milligrams of sodium, that's a tablespoon of patis.
Okay.
So we have to remember.
I hope that people
easy to
are able to use that.
But congratulations to the two of you, because right now we have more than 1,000 listeners in our Zoom and additional 100 plus in the YouTube. So I'm sure a lot of our listeners are really interested in learning about, of course, the bread and butter of most of us internists, hypertension. Debbie, I'd like to ask your inputs about, this is, I think, very important for all our clinicians or even our patients who are now using the oscillometric way of taking the blood pressure. Can you give us tips on how it can be validated? How can they make sure they're taking the correct blood pressure? Are there any standards or recommended BP machines for digital way of measuring blood pressure?
Thank you, sir, for that. Basically, there's a website, www.stridebp.org, wherein they have a list of validated blood pressure monitors, digital monitors. And then if you buy your monitors, there usually is, they're validated by societies like the American ACS, AHA, PSH, even validated two monitors. And then if they want to know how to measure their blood pressure, there are a lot of resources. So there's one in the Philippine Society of Hypertension website and the Philippine Heart Association website. It's a video on how to do your blood pressure monitor. But the caveat, sir, is it has to be, if it's on the right arm, it's always on the right arm. So when you take your blood pressure, it has to be in the morning upon waking up. Dapat hindi nag-exercise, hindi uminom ng kape, or anything that transiently increases your blood pressure. It has to be taken 3 times, 1 minute apart. Discard the first reading because usually there's a white coat effect, and get the average of the two. And then in before dinner or before bedtime, 3 times ulit, 1 minute apart. Discard the first reading and get the average of the two. But they have to synchronize it with the blood pressure that their healthcare provider did. So kung kanan yung ginawa sa clinic, dapat sa kanan rin. So that it merong pagbabasehan yung doktor. So pareho. Validation, sir, there are companies that actually recalibrates your blood pressure monitor every year. So you just need to ask the ones that sell you the blood pressure monitor regarding calibration. Pero may nagtanong rin sa akin yan. Marami kasi from Shopee, from China. So what I tell them, you can validate it with the blood pressure that your doctor has taken with you. So kung pareho yung BP mo, saka yung BP na tinake ng doktor mo, baka halos pareho sila. Marami kasing mura ngayon, sir, sa Shopee saka sa Lazada. Yes. Na BP monitor. So we want to be practical to everybody, and then that's how you can validate it on your own if the company does not validate it for you.
Thank you. Thank you.
Thank you.
There are actually a lot of questions, but unfortunately, due to time limitations, we will not be able to answer all. But please, Debbie and Sandy, if you have time, kindly answer all those questions in the question and answer box. But we still have a few more minutes, and I'd like to ask Sandy, I will check your culinary skills now. You've talked about DASH, which is American-based, and Mediterranean, which is European. Can you offer a sample meal for a typical Filipino family, considering the cost, considering the economics? You know, we don't have what was included in DASH and Mediterranean. So a sample Filipino meal that probably would be similar to what you have described in your DASH or Mediterranean diet.
Okay, so the first part of my response will be that first you need to know how much energy expenditure you are expecting for the day, or or for the next day, so that you know just how much calories you are able to take, right? You need to take note of your activity, like your size, I guess, and your age, so that you know how many calories you are allowed. But generally, if we're just talking about DASH or the Mediterranean diet, and I did mention it earlier, that's easy because the ingredients are simple and they're all we're able to incorporate them into regular Filipino meals or fare. For breakfast, you could have an egg, although maybe not the regular pandesal, but a whole wheat pandesal, right? You could also have oatmeal and fruit. People are into oatmeal right now, and fresh fruit that will still be compliant with the DASH or the Mediterranean diets. For lunch, I'd have a serving of chop suey and fish, even fried fish. If you fried your fish in oil, I know, in some situations it might not be so tasty, but trust me, it's tasty, right? You can fry a fish. And then for dinner, even a serving of chicken tinola, lumpiang sariwa with some brown rice. There we have to spend a little bit more if we want to be on the Mediterranean diet. You still are allowed your grains. You still are allowed some rice, but maybe rice like red rice or black rice, that kind of a thing. So just also be careful about, we like to, we all love sinigang, and I don't know how it is. Hopefully, most of the households would be able to cook sinigang with just natural ingredients. But I know that in mine, we love the sachets of sinigang, and that's just full of salt, right? The mixes that you can use. But so those things you need to be, very careful about. You need to be mindful of the things that you're adding onto your diet, because the ingredients are simple, but it's putting in too much salt, maybe putting in too much sugar that changes it, or changes the diet so that it's not compliant anymore. But most of our viands, most of our Filipino food, we are likely to be able to convert them so that they are compliant with the Mediterranean and the DASH diet.
Thank you, Sandy, and thank you, Cecil. There's a Pinggang Pinoy, right? I think we have one more.
One last. Yes.
James, go ahead.
Yes, Sir John. I think there's one last question from one of our YouTube viewers for Dr. Ona. So the question is, what is the stand of our specialists on omega-3 supplementation for BP control or prevention of cardiovascular or cerebrovascular events? So someone is curious about the omega-3 supplementation for that, Doc. What is the stand?
Usually the omega-3 is given for basically dyslipidemia, but then there are studies that show there's a study in the US, but the omega-3 that they've given is the pure one. So basically, if you have the pure one, then they saw that it can reduce your outcomes for patients with dyslipidemia on top of a statin. But with regards to prevention, basically there's still no studies that show this is kung ang outcome mo is cardiovascular prevention, right? So that's the outcome. So if you look at the outcome as that, then most of the societies have the stand would be, even for dyslipidemia and hypertension, but there's no really study yet to be able to prove that omega-3 fatty acid alone can reduce your cardiovascular outcomes as a supplement, no? As a supplement, Dr. John.
Yes.
For hypertension, wala siya eh. For dyslipidemia, hindi rin siya. It should, as statin pa rin. For other heart diseases, Dr. John, wala rin. No? Wala rin eh. So, no. I don't know where it came from, but it's not recommended at this point in time for prevention of cardiovascular disease.
All right. Thank you so
James,
much, Doc.
if I may add,
Yes,
so this really was what I was mentioning earlier, where they really have found that single nutrients do not provide that much benefit for either hypertension or cardiovascular disease. It really is, a good diet composed of several different nutrients. You cannot just single out or choose one nutrient and expect that it'll make a big difference. You're going to have to change a lot of things, and particularly your diet. So in the Mediterranean diet, they do stress the intake of omega-3, but it's in their fish. It's in their healthy fats that are included in the Mediterranean diet. They're not saying that you should, or it'll help you if you took a supplement. So it's still the overall diet that really matters.
Thank
you. So on behalf of our chairs and our chair and co-chair, Dr. Obilios and Dr. Villanueva, and of course my co-moderator, Dr. James Nazareth, would like to thank our speakers again, Dr. Ona and Dr. Cabral Prodigalidad, and of course all our listeners who joined us this afternoon. Thank you very much.
Thank you.
Thank you.
Thank you, speakers and moderators. We would like to award the Certificate of Appreciation to Dr. Deborah Ignacia Ona for her invaluable contribution as a resource speaker on anti-hypertensive treatment strategies and prevention of complications during the UP College of Medicine Grand Scientific Symposium. This Certificate of Appreciation is given to Dr. Patricia Ann Cabral Prodigalidad for her invaluable contribution as a resource speaker on DASH, fad diets and supplements during the UP College of Medicine Grand Scientific Symposium. We would also like to award the Certificate of Recognition to Dr. John Ananuevo and Dr. Christian James Nazareth for their contribution as moderators for the focus session on cardiology and gastroenterology. Given this 22nd day of September 2021. Signed, Dr. Maria Assumpta Cecilia Serrano, President of the UP Medical Alumni Society, Davao Region, Dr. Charlotte Chong, Professor and Dean of the UP College of Medicine, Dr. Teresa Luisa Cruz, Director of the Postgraduate Institute of Medicine, and Dr. Lara Teresa Alentahan Aleta, President of the UP Medical Alumni Society. We would like to thank our sponsors for their support in this year's University of the Philippines College of Medicine Grand Scientific Symposium. Please stay for a second focus session on pulmonology, which will begin after the industry-sponsored lecture.
Superzits is a play of words which I have invented, and this is from superzits, which is from superacne, which is from superbug. Superbugs is the informal term used to refer to bacteria that have become resistant to antibiotics, which are usually used to treat them. Examples of superbugs are methicillin-resistant Staphylococcus aureus or MRSA, vancomycin-resistant Enterococcus or VRE, and ESBL or extended-spectrum beta-lactamase-producing Enterobacteriaceae. So superzits have here referred to acne caused by bacteria which have become resistant to common antibiotics used to treat them. Good day, I am Dr. Maria Cristina Batak from the Department of Dermatology of the UPPGH and from the Department of Medical Microbiology of the UP College of Public Health, and my lecture is entitled Zooming into Superzits, Nadifloxacin for Acne. This is a company-sponsored lecture by Inoderm, and I will be receiving an honorarium. Before we go to superacne, let us review the basics about acne. Acne affects 85% of teenagers and persists to adulthood, affecting 12% of adult women. Although not a life-threatening disease, It is associated with significant physical and psychological morbidity, such as permanent scarring, poor self-image, depression, and anxiety. Acne is a primary inflammatory disorder involving the pilosebaceous unit, diagnosed by the presence of comedones, which is considered its pathognomonic feature, papules, pustules, nodules, and cysts. Acne pathogenesis is multifactorial, involving four key factors with interrelated mechanisms. Hyperkeratinization of the follicular infundibulum, which leads to the development of the microcomedo, increased sebum production, Cutibacterium acnes proliferation, and inflammation. In addition to these main causes, there are other factors that contribute to acne pathogenesis, including genetics, diet, environmental factors, and hormones, particularly in disorders with hyperandrogenism, such as polycystic ovarian syndrome. These factors in acne pathogenesis are addressed by the following available acne treatments. There is no single modality that can address all these factors, although some may be able to address more than one of these factors. For example, retinoids are able to address almost all these factors, including hyperkeratinization, sebum production, and inflammation. It does not reduce proliferation of Cutibacterium acnes. That is why retinoids are usually paired with topical benzoyl peroxide and antibiotics to address this aspect of acne pathogenesis. This illustrates that combination treatment is key to achieving treatment success in acne. It is now time to meet Annie, the anxious teen. Annie is a 17-year-old healthy teenager who consulted for pimples on her face, which had seemed to increase since the initial lockdown in March 2020. She says that she regularly washes her face with kojic soap and occasional facial scrubs. She has no known allergies, and both her parents had acne as teens. She says that she is getting bothered by her pimples, especially since they are now more noticeable during Zoom sessions for her online classes. After taking a good history, it is now time to assess Annie's acne severity. What are the things that we look for? We look at the type of lesions, quantity, extent, and presence of post-inflammatory changes. So what are her lesions? Does the patient have non-inflammatory lesions, such as open and closed comedones, which we commonly call blackheads or whiteheads? How about inflammatory lesions such as papules, pustules, nodules, or cysts? Quantity, are they few, several, or many? How about extent? Are they limited to only a particular area of the face? Are they distributed to the whole face? Is the chest involved? How about the back and the shoulders? Are there post-inflammatory changes such as erythema, hyperpigmentation, and scarring? Then we determine acne severity. Does the patient have mild, moderate, or severe acne? Look at the types of lesions, again, number, extent, and presence of post-inflammatory changes to assess acne severity. If there are few to several papules and pustules and no nodules, then the patient has mild acne. Several to many papules and pustules and few to many nodules, patient has moderate acne. Numerous or extensive papules and pustules and many nodules, the patient is classified to have severe acne. This is mild, moderate, and severe acne. How about Annie? Our patient has several comedones, several papules and pustules, but no nodules. So we can say the patient has mild to moderate acne. Now, why do we need to assess severity? It is important to assess severity because this will guide our treatment. This is the acne treatment algorithm from the Guidelines of Care for the Management of Acne Vulgaris of the American Academy of Dermatology in 2016. We will focus on the first line treatment for acne. Since our assessment is mild to moderate, we decide to give her retinoids, benzoyl peroxide, and topical antibiotic. Topical retinoids make up the core of acne therapy and are used for initial treatment and for maintenance of acne. They are vitamin A derivatives that are both comedolytic and anti-inflammatory. Examples of topical retinoids are tretinoin and adapalene. Benzoyl peroxide works as an antibacterial agent and is mildly comedolytic. It kills Cutibacterium acnes by creating free oxygen radicals. Resistant Cutibacterium acnes to benzoyl peroxide has not been reported, and its addition to regimens of antibiotic therapy enhances results and may reduce development of resistance. Topical antibiotics accumulate in the follicle where the Cutibacterium acnes are found. Some topical antibiotics are anti-inflammatory aside from having antibacterial actions. They are best used with benzoyl peroxide, which increases efficacy and decreases development of resistant bacterial strains. Monotherapy is not recommended because it increases the risk for the development of antibiotic resistance. Our present regimen will then be able to target all four aspects of acne pathogenesis: hyperkeratinization with retinoids and benzoyl peroxide, which is mildly comedolytic, seborrhea with retinoids, Cutibacterium acnes with benzoyl peroxide and antibiotics, and inflammation with antibiotics and retinoids. However, when Annie heard the word antibiotic, she became pensive. She had read about super acne and how the use of antibiotics for acne had contributed to their development. She then opened her cell phone and in no time showed you the following articles. Super acne, drug-resistant zits on the rise. Yikes, there's a new thing called super acne and it might be resistant to antibiotics. Warning, super acne is real, rising, and impossible to treat. So what's the real score with super acne? Antibiotic resistance in acne treatment is one of those things that fall under seeing is believing. We do not see it in practice. It is not something visibly apparent to us because we do not usually submit acne swabs as we do with pus from purulent cellulitis or from an inflamed surgical wound. We may believe it in principle, but not in practice. There are various topical and systemic antibiotics that have traditionally been used in acne management. And among the topical antibiotics, we have erythromycin and clindamycin. The sad thing is that there are numerous studies that have revealed rising numbers of Cutibacterium acnes resistant strains from all over the world. And this was summarized in a study published in 2014 looking at resistance of Cutibacterium acnes to clindamycin, erythromycin, and doxycycline in different countries. In a more recent study done among acne patients in Jordan in 2020, there were high resistant rates of Cutibacterium acnes to various antibiotics, such as doxycycline, tetracycline, erythromycin, and clindamycin. In 2020, an anti-acne topical antibiotic was launched and introduced in the Philippines, and this is nadifloxacin. Nadifloxacin? Come again? What is nadifloxacin? Nadifloxacin is a highly potent quinolone antimicrobial agent, a topical DNA gyrase inhibitor for the treatment of acne vulgaris, available as 1% topical cream. It has a broad spectrum of activity against a wide variety of pathogenic bacterial species. It received approval in Japan for use in acne vulgaris in 1993, and the indications were expanded in 1998 to include other skin infections, including those caused by methicillin-resistant staphylococci. Now, what makes nadifloxacin a good topical antibiotic for acne? It has low resistance rate, it causes low systemic absorption, it is safe, and has additional properties. So before 2020 here in the Philippines, we usually use either of these two topical antibiotics, and these are erythromycin and clindamycin. And in this study, we can see that there are isolates of Cutibacterium acnes resistant to erythromycin and clindamycin in many countries around the world. In this study by Nenov, published in 2021, in vitro activity of nadifloxacin was assessed and compared with erythromycin, clindamycin, and tetracycline against Cutibacterium acnes. And out of 73 isolates cultured from 115 samples, no isolate was found to be resistant to nadifloxacin, whereas 4% were resistant to clindamycin and 15% to erythromycin. So nadifloxacin is a good topical antibiotic for acne. It causes low systemic absorption. Percutaneous application of 10 grams of 1% nadifloxacin cream to healthy volunteers resulted in the peak plasma value of 1.6 nanograms per ml 8 hours after dosing, indicating extremely low absorption. It is safe and has caused only minor side effects at the site of topical application and has additional properties, including anti-inflammatory effects and anti-androgenic effects. It may then consequently affect sebaceous gland activity and therefore decrease sebum production. Unfortunately, it is relatively easy for bacteria to develop drug resistance through 3 simple steps: acquisition by microbes of resistance genes, expression of those resistance genes, and selection for pathogens expressing those resistance genes. The selective pressure in favor of resistance occurs whenever microbes are exposed to a drug but not eradicated. A setting that favors this selective pressure is poor patient compliance. Drugs that inhibit but do not kill microbes are more likely to allow some microbial cells to live and therefore develop resistance when exposed to a drug. Also, abuse of broad-spectrum antibiotics has further encouraged the development of many antibiotic-resistant strains. So here are some ways by which we can prevent drug resistance whenever we manage our acne patients. First is for us to stop using over-the-counter antibiotic ointment for every biopsy or minor procedure. Second, oral and topical antibiotics for acne should only be used temporarily for a necessary minimum period, at the most 3 to 4 months. To always combine a benzoyl peroxide with a topical or oral antibiotic to hit the bacteria with multiple mechanisms of antibacterial activity to limit resistance. Avoid concomitant therapy with chemically dissimilar antibiotics to reduce the risk of resistance developing in both. If in a patient, one can choose to give either a topical or an oral antibiotic, choose topical antibiotic first. And once inflammatory lesions, such as papules, pustules, nodules, and cysts have resolved, withdraw the antibiotic and maintain the patient on topical retinoids or benzoyl peroxide. And lastly, maximize the use of non-antibiotic treatment, such as spironolactone hormones and oral isotretinoin for moderate to severe acne patients. Now, these studies show that the addition of nadifloxacin had enhanced efficacy of benzoyl peroxide and adapalene. So nadifloxacin is a good topical antibiotic for acne. It shows low resistance rates, causes low systemic absorption, it is safe, and has additional properties, including anti-inflammatory and anti-androgenic properties. And aside from this, nadifloxacin can also be used for bacterial skin infections. It has been shown to have excellent in vitro activity against Staphylococcus aureus, Staphylococcus epidermidis, Streptococcus pyogenes, et viridans, E. coli, and Cutibacterium acnes. It has effects against impetigo, secondary infected wounds, folliculitis, and impetiginized dermatitis, and has caused reduction in erythema, exudation, swelling, pain, pruritus, erosion, crust, and scaling, as well as eradication of causative bacteria. This is Nadixa, nadifloxacin. So in summary, there are isolates of Cutibacterium acnes that are resistant to topical and oral antibiotics used to treat acne. None to very low proportion of Cutibacterium acnes have been found to be resistant to nadifloxacin. And although nadifloxacin has been found to be an effective anti-acne treatment as monotherapy, it is recommended that it be administered together with benzoyl peroxide or with a topical retinoid to prevent resistance. So with this, I hope you're ready to zap the super zits.
Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections.
We now proceed to our second focus session, which is on pulmonology. The chair of this session is Dr. Jessie Arcasitas. Dr. Arcasitas is a pulmonologist and the previous chair of the Department of Internal Medicine in Southern Philippines Medical Center.
Good afternoon. Pneumonia is a common condition seen in the pediatric and adult clinics. It continues to be one of the top 10 causes of mortality and morbidity in our country. It utilizes a bulk of our healthcare resources and is one of the top claims for PhilHealth. This afternoon, two distinguished speakers will guide us through the basics of pneumonia. This will be followed by an open forum where everyone is welcome to ask our resource persons. Our first speaker is Annalisa Ong Lim. She's a graduate of UPCM class 1992. She's presently the chair of the Residency Training Committee and a professor and attending pediatrician at the Department of Pediatrics, University of the Philippines College of Medicine, Philippine General Hospital. She had her residency in pediatrics as well as her fellowship in pediatrics infectious diseases at the UPCM College of Medicine, Philippine General Hospital Medical Center. She is a trustee of the National Philippine Pediatric Society and the immediate past president of the Pediatric Infectious Disease Society of the Philippines. Our second speaker is Dr. Lenora Canizares Fernandez. She is a graduate of the UPCM class 1989 and is currently an associate professor 3 and section head of the section of Pulmonary Medicine, Department of Internal Medicine, UPCM PGH. She is the division head of the Division of Pulmonology of the Department of Medicine, Asian Hospital and Medical Center. She is the consultant coordinator of the Comprehensive Ambulatory Respiratory Care Program and Stop Smoking Program of the Philippine General Hospital. She is currently the coordinator of the Office of Continuing Medical Education, University of the Philippines, Manila. She had her residency in internal medicine and pulmonary fellowship at the same center, UPCM, Philippine General Hospital Medical Center. She is a past president of the Philippine College of Chest Physicians. So, good afternoon. Our moderators for today is yours truly, Jessie Orcasitas, a graduate of UPCM batch 1995, as well as Ahmad Umusari, a graduate of UPCM class 2017. So Ahmad, can you start the first question?
Yes, thank you, Dr. Jessie Orcasitas, for that wonderful introduction. For this afternoon, we're going to discuss about pneumonia. So meron po kaming mga nakalap na questions for this afternoon. So our first question, or it's in Tagalog, ano ba ang mga sintomas ng pulmonya? May pagkakaiba po ba ito, ang mga sintomas, sa mga bata at sa mga nakatatanda? That's it for the question.
So Dr. Raong, would you like to start?
Yes, magandang hapon po sa ating lahat and maraming salamat sa tanong na yan, no, Ahmad. I think pneumonia kasi is one of the very common conditions that people need to be aware of kasi leading cause pa rin siya ng morbidity and mortality sa atin sa Pilipinas. So if the question is how does pneumonia present, no? Karaniwan para sa mga bata, ang hinahanap talaga nating cardinal symptom, of course, yung cough, and maaaring meron siyang respiratory difficulty. So nakikita natin dito sa slide na to yung mga positive predictors ng radiographic pneumonia. So kung nakikita natin na ang bata ay may ubo at merong takip niya at merong retractions or may fever at iba-iba pang mga simptomas ng respiratory difficulty, mataas ang chance na positive ang kalalabasan ng kanyang chest film. So siguro yung isa kailangan ko lang din idagdag is yung definitions ng fast breathing or takip niya. Kasi nga alam naman natin sa pediatrics, this is age dependent. And so we usually want to look for respiratory rates 50 and above for children 2 to 11 months. And for those who are 1 to 5 years, we are looking for rates that are at least 40 and above. Yung isa ring mahalagang simptomas na tignan ay yung chest indrawing. And I just like to show these two pictures. So ito yung tinitignan natin dun sa lower portion ng chest na merong indrawing ng portion na ito kung the child breathes in. And it's also typically seen quite well here in this particular picture. Thank you. Lenny, would you like to add anything for adults?
Thank you, Anna. Now, similar to the ones for the kids, sa adults naman po, we also use a lot our physical exam and our symptoms also. So pinagbabasihan ko po yung diskusyon sa maraming guidelines at ito po silang pertinent at napakahirap nowadays because of the COVID-19 pandemic, di ba? So parang na-muddle up na talaga lahat. Now, let me just share with you that we have an update of that very important 2016 na adult CAP guidelines, which dictates our PhilHealth. Meron na pong 2019, pero draft pa lang ho siya. So, kung ma-approve ito, aakyat po ito hanggang PhilHealth ulit, and that might modify, pero sasabihin ko na sa inyo na it's basically the same as before. Medyo mas marami lang antibiotics ang mga preference na ngayon because of the new other antibiotics that are present. So kung makikita natin dito sa adult, importante syempre yung 2 weeks na duration natin po. Kasi kung ang symptoms niya ay more than 2 weeks, baka hindi na po yan pneumonia at iba na ang dahilan. And then as similar to the pediatric population, cough is very important. Nandun din po yung takip niya natin. Kaya lang medyo mahirap. Hindi na natin binubuksan minsan yung chest, no? Yung clothes minsan, and then we just count the rate unless now we try to auscultate our patients. So, mahirap na naman nowadays dahil sa COVID-19. So, kami nga mga pulmo, hindi na nga kami masyadong nakaka-auscultate kasi kung naka-level 4 PPE kami. That's difficult. So, if we look at our COVID-19 na algorithm, medyo magkapareho sila. So mahirap talaga ma-differentiate sa totoo lang, no? Whether it's COVID-19 infection or kung pneumonia siya from another cause aside from our SARS-CoV-2. So in sa adult community acquired pneumonia, alam po natin na our batting average in terms of having really the correct diagnosis of community acquired pneumonia just based on our physical exam and our symptoms is just 60 to 76%. Therefore, for pneumonia, we do need sana po ang chest x-ray to confirm the diagnosis of pneumonia. So basically, baka yun ang malaking difference natin, Ana. Now, for us, we do need sana the x-ray to confirm or establish a diagnosis of pneumonia. That's for adults. So, Jess?
So, I think nasagot na ni Doktora, no? Yung partly, yung isa sa mga tanong ng ating mga kasama sa sa practice, so ang X-ray po talaga ay isang requirement para sa diagnosis ng pneumonia. Halimbawa, ma'am, no, sa mga lugar, no, katulad sa rural areas na walang X-ray or mahirap, no, ang resources, no, lalo na sa X-ray, enough na po ba na ma-diagnose ang pneumonia clinically, no, for both adult and pedia patients, no? Aside sa X-ray, meron pa bang kinakailangang laboratories na kailangan magawa para mas matukoy, no, kung meron ba talagang pneumonia ang pasyente?
So, Ana, sasagutin ko muna for the adults, no? So, meron tayong leeway, no? Kasi kung ganito ang sitwasyon natin, halimbawa dito sa picture na to, ang layo-layo, no, walang X-ray, pa-X-rayhan talaga, no? Ahmad, ganun ba sa area mo doon sa province? Meron pang may mga sitio ba or may mga barangay na ganun ang situation?
Yes po. Well, kung lang naman sa may tao, meron namang X-ray, pero marami pong mga rural areas talaga na mayroon.
Oo nga eh. Yeah. So, right. So in our guidelines, we put there that the chest X-ray may not routinely be done. Kasi kung talagang sure na sure ka clinically na pneumonia siya, then go ahead and treat, no? So kaya lang maganda sanang magawa yan as a confirmatory na laboratory po natin.
Sa pedia naman po, Doc Ong, would you require the same diagnostic test? Or can we go clinically for pediatric patients?
Well, if you recall, no, siguro during training, nung nagsisirotate ang lahat sa pediatrics, ang tinuturo sa atin parate, takip niya is a very sensitive sign for picking up pneumonia. Pero I'd like to share this study, mainit-init pa, just published nitong nakaraang taon, nung Abril, and they wanted to look at the clinical predictive values of these signs and symptoms for radiographic pneumonia. And part of the team that worked on this was Dr. Lucero, who's very well respected as a researcher in pediatric pneumonia. So we can be sure that the lens of developing country settings has really been included in this particular analysis. So tinignan nga nila kung magiging maganda bang indicator for predicting radiographic pneumonia, yung individual findings na karaniwan nating tinitignan tulad ng takip niya or lower chest indrawing. And out of this study, which included 15,000 children, nakita nila na actually mababa palang specificity ng individual findings. So kung takip niya alone or chest indrawing alone, medyo mahirap mong sabihin na pupusta ka na makakakita ka ng pneumonia on chest x-ray. However, all is not lost. May pwede pa rin tayong gamiting clinical findings, and sinasabi nila na pag kinumbinasyon mo, for example, ang takip niya and fever, or takip niya and hypoxemia, or fever and hypoxemia, this led to improvement in the sensitivity of the test, or rather in the specificity rather of these particular signs. So, ang sabi nila, what we actually need to do is to combine these signs and symptoms, so temperature and respiratory rate and oxygen saturation, to improve specificity. So ang translation siguro nito in the clinical setting is kung nakakakita tayo, for example, ng pasyenteng may ubo, tapos meron siyang konting hingal, syempre in your mind, isipin mo, pneumonia kaya to or asthma? So you add one more symptom, whether that's temperature or oxygen saturation, one more finding rather, and if both are present, then you have a higher probability of getting a positive chest film if you ended up doing that. So, ang bottom line, kailangan nga ba? Pwedeng wala. Basta meron ka ng mga signs and symptoms, and better if you can find them in combination. Lenny?
Yeah, so basically I said na nga na even the constellation of symptoms would just give us 60 to 70%. So lalo na siguro kung tayo ay nagpapa-reimburse sa PhilHealth, nagiging issue nga yan. So talagang nandun si X-ray kasi talaga lahat ng guidelines magsasabi for us to make the definite diagnosis of pneumonia, then that's it. Lalo na sa adults na maraming ang pupwede ding maging dahilan na magde-desaturate yung pasyente at magiging takipnik nga. So siguro mas madami kasing differential sa mga adults compared to kids. So that's why we're bound to that, but it doesn't prevent us from treating, initiating yung treatment for our patients.
So importante pa rin talaga yung sinasabi sa atin, yung physical examination at saka yung history, no? So the more na maraming senyales, mga simptomas na nakikita, mas tataas yung posibilidad na ang pasyente nga ay merong pneumonia. Okay. So siguro hasang-hasa yung ating mga graduates sa ganoong paraan. Doc, paano naman po natin malalaman ano yung mga palatandaan na lumalala na o malala ang kalagayan ng isang pasyenteng may pneumonia? Ano bang mga dapat natin bantayan sa mga pasyenteng may pneumonia para matukoy natin kung kailangan ng ipadala ang mga pasyenteng ito sa mga centers na higher ang kapasidad or kailangan nang i-admit ang mga pasyenteng ito.
Okay, let me start off.
Yeah, Ana, mauna ka na.
Oo, sige. So I just like to share this slide where the signs and symptoms that are listed here are taken to indicate severe pneumonia. So this is coming from the WHO, which we know naman puts a premium on clinical diagnosis and also supports these particular essential signs and symptoms with a lot of research to guarantee or rather to support that it is a sensitive and specific finding. So sabi nila, pagka pasyente mo ay merong cough or difficulty breathing, mababa ang oxygen saturation if you have capability to measure it, or meron na siyang central cyanosis, accompanied by severe respiratory distress, which in children can present as grunting or very severe chest indrawing, with a general danger sign. So in kids, this is something that has to do with their activity. Either hindi na sila baka breastfeed, or they have lethargy, or reduction in the levels of consciousness, or even convulsions, which can be a sign of hypoxia. Then this will be classified as severe pneumonia and requires urgent admission to the hospital for oxygen support as well as for antibiotic treatment. Lenny?
Sa adults naman, gusto namin mas complicated ang buhay. Siguro. Tapos, meron kaming mga prognostic scorings na sinasabi. And isa nito, I'll just share. Sandali lang po, ha. Okay, there you go. Am I sharing? Is it coming out?
Yeah.
Yeah, okay. So there are many kinds of scoring systems, and ang isang sikat namin to have the prognostic indicator is called the curve 65. Simple lang siya, confusion, BUN, respiratory rate, blood pressure, age. Kaya lang, kung makikita natin, we still need to do a laboratory, which is getting the BUN. So it's kind of cumbersome, pero sa mga hospital, ito ay isang ginagamit po to prognosticate kung ano yung chances of a person with pneumonia dying. And then ito mas toxic pa. So ito yung recommended sa American Thoracic Society at sa IDSA sa Amerika. Kaya lang makikita nyo, napaka laboratory intensive, ABG, BUN, and everything, no? So usually sa totoo lang, hindi na rin namin ginagamit yan even at the start, no? So siguro nasa ICU na this is the time that we give it. But bottom line is, why do we need to prognosticate? It's to determine ngayon or to triage kung saan natin aalagaan or ititreat ang pasyente, whether outpatient or sa ward or sa ICU. So ito, we know this by heart. It is still the same. This was crafted in 2006, 2010. Up to now, this remains the same. We label our patients as low risk cap, moderate risk, or high risk. And that will dictate for us kung low risk lang po ang pasyente, outpatient ang treatment natin. And kung moderate risk, ward tayo. And then kung ICU or high risk, then usually the patient is in the ICU. And katumbas din dito yung intensity din ng mga laboratories na nire-request natin. For example, sa outpatient low risk cap, hindi na tayo magsusputum gram stain culture. Pero kung sa moderate risk and high risk, when we treat them supposedly in the hospital, then our guidelines would dictate also now we have to do these kinds of things to confirm the diagnosis and try to look for the etiologic agent. So dito makikita po natin yung mga ating mga symptoms, no, that we look at to determine now the severity. So you know this, and this would be also pertinent kung talagang nagfulfill ang pasyente nito, then your patient can be labeled also as septic, and that means then they will have really to be hospitalized. Otherwise, kung wala po sila nito, low risk lang po sila. Now, dito sa number 7, kung makikita natin, nakalagay dyan unstable comorbid conditions. Kasi madami sa mga matatanda na madami silang comorbidities. So ngayon, factor din po yan na medyo benign lang yung pasyente tingnan, sigurado kang may pneumonia, but naging unstable. Halimbawa, nagkaroon siya ng heart attack or yung diabetes niya, tumaas masyado yung sugar. Now, that will also be an indication now to label your patient as moderate risk cap, and that might now warrant a hospitalization even if the pneumonia isn't really that bad. So ito yung mga implications sa adult, mas madaming pasikot-sikot po.
Okay. Nandoon pa rin si X-ray, ma'am, ano? So sa pinakasimple na guideline, nandoon pa rin yung X-ray at saka yung pagtukoy, no, ng oxygen saturation. So pwede naman po siguro, ma'am, yung oxygen saturation lang, no? Hindi naman natin, although isa sa binabantayan natin yung sinasabi nilang CO2 retention, pero pwede na yung mababa ang oxygen para mas maano natin yung kung delikado na yung pasyente natin at kinakailangang maipunta sa ibang centers, no?
Ang problema lang, Jess, kung ganyan ka-toxic yung pasyente na ina-admit mo, it's at least, well, you have to know kung may mga ibang differentials. No? So that's where the X-ray really also
really comes in. Oo. Kasi sabi nga ni na Ahmad, no, mayroon daw silang kasama, ma'am, na 6 hours pa yung yung nearest X-ray, no? So medyo limiting factor talaga. Oo. For some of our graduates.
It doesn't deter us from continuing treatment. So medyo delayed lang yon, kaya lang we proceed with empiric treatment.
Sige, okay. Ahmad, would you like to ask the next question?
That po, parang na-discuss na natin yung parang magandang review din ito no, as a primary care given sa rural areas. Parang it's a wonderful avenue to review din yung mga dating concepts ng pneumonia. It's good to know na hindi pa talaga na-change yung groupings, lalo na sa adult, pero syempre mga complicated certifications din. Moving on po sa ating next question. Ngayon, tayo dadako naman po sa treatment. So ang tanong po ay, paano po natin ginagamot ang pneumonia? Meron po bang pagkakaiba ang gamutan sa bata at sa mga bata? So when do we start for treating a patient for treatment?
Ana, mauna ka na ulit.
Sige. Okay. So, 'di ba, since ang main problem naman talaga natin or ang critical need ng isang pasyenteng may pneumonia is ensuring adequate oxygenation, makikita natin that the references always emphasize the need for providing adequate oxygen supply. And for children, pagka yung oxygen saturation mo is less than 90% or pagka may distress, no, you're safe to actually provide oxygen therapy. In this case, no, ang sinasuggest niya is to use initially nasal prongs, and sabi nga nila pagka wala kang nasal prongs, pwede kang improvise using a nasopharyngeal catheter or a nasal catheter, so that you're able to deliver the oxygenation that's required. Sinasuggest din nila na sana gumamit tayo ng pulse oximetry to guide oxygen therapy. And pulse oximetry can also be helpful for guiding us as we wean from oxygen support. Pero alam din natin na mainstay talaga ng treatment ng pneumonia ang antibiotics. So, syempre, iisipin din natin ngayon sa konteksto ng COVID na marami ding mga pasyente na ang presentation ay pneumonia and yet COVID ang problema. And in those cases, of course, hindi naman always necessary mag-antibiotics. Pero siguro, kung pag-uusapan lang natin ang community-acquired pneumonia as a whole, no, karamihan pa rin ng mga bata, ang problema is bacterial pneumonia. And the typical pathogens still include yung ating mga vaccine-preventable pathogens like strep pneumo or H. influenza. Kaya ang pinapang-cover pa rin natin ay yung ating old standbys or old reliables. Dito sa WHO manual, they're saying ampicillin and gentamicin, and in cases of failure of first-line drug, ceftriaxone. Pero we actually also have what is called the National Antibiotic Guidelines, and this latest edition from 2018 shows that CAP in infants and children are typically caused by, as I mentioned, strep and H flu with sprinkling of staph and other gram-negatives. So in that case, you may take a history, and if the patient already is able to say that Hib vaccination was completed, then Amox can be an option for non-severe pneumonia. And for those who are not vaccinated with Hib, then they need to receive a slightly broader spectrum utilizing a BL-BLI combination like amoxiclav or a second-generation cephalosporin. Now, for PCAP-C patients or those who have severe infection, which we already defined earlier as showing severe respiratory distress, no? Then we want to provide IV antibiotics, and ginagaya actually, or rather consistent, no, yung recommendations ng National Antibiotic Guidelines with that of WHO. Ang options dito, first line is ampicillin or penicillin. And kung unvaccinated or unknown ang vaccination history, we want a broader spectrum. Dito na papasok yung second generation or third generation cephalosporins. For those with very severe pneumonia, no, as evidenced by very severe respiratory distress or risk factors like dehydration or malnutrition, then this will require specialist guidance, and typically dito tayo nagsastart ng broader spectrum with more gram-negative coverage. For adolescents, halos katulad or may overlap yung kanilang microbial flora with that of adults. And dito na pumapasok yung need for adding macrolides because it might be very difficult to distinguish between atypical pneumonias and the usual bacterial pneumonias. So, siguro yung isang pwede nating tip para sa clinicians is that a patient presenting with systemic signs and symptoms like malaise, pharyngitis, headache, cough in a child who does not appear ill, who is more than 5 years old and has or in the adolescent age group, may benefit from macrolide treatment because of the possibility that this is a typical pneumonia. Lenny?
Yeah. Thank you, Anna. So, actually, Ana, medyo may pagkakapareho din pala ang community-acquired pneumonia sa adult and sa
Pedia.
pedia. So, in terms of, sandali lang po ha, ayun, share. So, in terms now of yung antimicrobial treatment, dito ako nag-concentrate. Sinabi ko nga kanina, minsan kahit walang x-ray, we proceed nga with the empiric treatment. Kasi nga, sometimes there's the urgency and as we mentioned, there's the logistic limitations there. So we now base it on what we know about yung local pathology or local milieu natin in terms of the most common microbes that cause pneumonia. So when do we give antibiotics? Now, ito very important sa amin. Now, we have to initiate the antimicrobial treatment kung ano man siya within 4 hours of the diagnosis because it has really been shown na it increases mortality. So, as Jessie mentioned, nakakapatay talaga ang pneumonia. Lalo na sa adults nga, it's actually the number 4 killer throughout here in the Philippines. Kaya very important yung immediately starting it, yung within 4 hours. So kung anong klaseng antibiotic ang ibibigay, as Ana mentioned, kung anong nasa milieu natin, and kung ano din ang susceptibility ng ating mga microorganisms. So very important din po na alam ninyo kung ano ang resistance pattern at susceptibility pattern ng mga mikrobyo sa inyo. And I'm sure you're treating patients also with hospital-acquired pneumonia, and that is also very important. So unfortunately, dati iniisip natin, pag mag-diarrhea ang pasyente, kung yung pre-COVID pa lang, siguro atypical na organism yon. Alam natin hindi po yun totoo. There is no specific din na clinical symptom which can predict to us kung ano yung likely na pathogen. So we rely on the epidemiology natin, and similar to the children, it's still strep pneumoniae and H. influenzae, which are the top organisms. And as Ana mentioned, yung atypicals po are present, and that would mean the chlamydia, your legionella, and mycoplasma. And unfortunately for adults, as I mentioned, madami silang comorbidities. Now that plays a big role now in terms of changing the milieu or the flora that the patient might have, and kung ano yung offending pathogen. So this is a very nice study. This was done in Leyte, no? So it's also an eye-opener for me. So this was done for hospitalized nga lang. So patients seen in the hospital in Leyte, and it had 535 patients. So this is a very good view for you kung nasa probinsya kayo. It might be the same for you if you're not in the urban centers. So as you can see, it's still strep pneumoniae and H flu, but look at that. Klebsiella pneumoniae is high, even in the rural setting. And makita po natin dito, tuberculosis is also very frequent. It's 9.8% among patients presenting with a 2-week syndrome of cough, fever, and tachypnea among adults. So, ang iniisip namin, it might be a comorbidity, and it was considered as the most common comorbidity here in this local study, or the TB might be starting and presenting primarily as a CAP syndrome. And then we just, kasi di ba ang cut-off natin, isipin natin TB more than 2 weeks. Kaya lang, syempre pag magsimula din ang katibihan, ay magsa-start din muna siya ng cough and fever and the other symptoms, no? So probably this is something for us, lalo na sa COVID situation ngayon, na we also have to check for TB. Do not forget, no, to check also for tuberculosis sana. And then we always rely on Dr. Carlos' continuous surveillance report for us to see kung ano na susceptibility pattern ng mga mikrobyo po natin, no? So this was updated for 2020, and among the respiratory specimens, Klebsiella, Pseudomonas, Acinetobacter yung nandoon sa national survey natin. Kaya lang, let's not regard it na ito yung most common organisms, because most of the contributors there were big hospitals from Visayas, Mindanao, and Luzon. And therefore, medyo skewed siguro yung population na madami are gram negs coming from the hospital. Nevertheless, we have to keep that in mind. And then, come COVID pa. So ngayon, syempre, ang big issue, kung COVID confirm yung pasyente mo, pagpasok sa hospital, bibigyan mo ba ng antibiotic? So malaking question po yan. And then many meta-analysis so far worldwide would show that sa totoo lang, coexisting bacterial infection in our COVID-confirmed patients is not that high. So initially, in the first UK na survey, it was just 10%. And then it rose up to 19% with the latest dito na meta-analysis. And actually, most of our bacterial infections among our COVID patients are the super infection that happens at the latter part or the latter course of our patient. But mind you, if it's present, it does indicate a higher mortality rate for our patients, especially for those na super infection. So in this same meta-analysis, where this is called from different studies throughout the world, the top na co-infection when a COVID patient comes in na bacteria is Klebsiella and strep pneumoniae pa rin po. And let's not forget the virus. So akala natin COVID lang. So 22% among them would also have a coexistent influenza A na infection din. So medyo talagang toxic, no? It's kind of hard really to deal with our COVID patients. And if we'll remember now our ARSP again, ano ang susceptibility pattern? This is reassuring for strep pneumoniae. We still have good susceptibility to penicillin and to ampicillin, for example, to our simple beta-lactams. And that's why for adults, you will see later, kapareho lang po sa pediatric population. Now, we actually still recommend ampicillin, no, for our low risk without comorbidities. Tapos sa H-influenza, makikita po natin na still it's quite good except for cotrimoxazole. If you're targeting H-flu, we shouldn't give that because there's a high resistance. I mentioned Klebsiella because this is common, especially among our patients with comorbidities. And if we will note, medyo mataas ang mga resistance pattern nila to our simpler beta-lactams, for example. Although when we treat them in the inpatient setting, then still there's a good chance that we can give actually our ceftriaxone still. Although we do have to watch out for possible resistance patterns. Among adults, ito yung dreaded natin. Pag makakita na tayo na Pseudomonas na mikrobyo at Acinetobacter baumannii. Pag ganito na, wala na. Talo na tayo sa laban nito. No? Kasi it's usually multi-drug resistant now, and then there's really a high chance of mortality, especially when we're dealing with our ABOW, especially in the nosocomial setting. So, Ana, ididiretso ko na lang to ha. So with our current guidelines, yung sabi ko nga updated in 2019, these are now the recommended antimicrobials. So kung low risk ang pasyente nyo, outpatient without comorbidities, ano po ang binibigay? Tingnan nyo, amoxicillin pa rin po ang recommendation natin. And that's where the alternative of the macrolide can come in. But because of our flora nga na nakita, it's still okay to give amoxicillin pag walang comorbidity ang isang adult. And then it's an alternative to give the macrolide or even doxycycline. Now, if your patients now would be categorized as low risk, you opt to treat them outpatient, and their comorbidities are stable. Herein, we have to consider the presence of E. coli and possible Klebsiella even, and that's why we go up in terms of our antimicrobials. We now consider giving the coamoxiclav, for example, or your second-gen cephalosporins, and eto na po, no, we recommend even outpatient na dual therapy na po kapag may comorbidity ang pasyente and you opted to treat outpatient. And what is the reason for that? So as mentioned by Anna, we are thinking also of more atypicals present in our adults. So it's not just in the pediatric population, and we do have to cover for that. And we put there the alternative treatment of our fluoroquinolone. But as you know, we try to protect this antibiotic. We try not to give it, because this is also our medicine as second-line drug for our many patients with tuberculosis. So, ito na po ang mga moderate risk na ito yung inpatient na ginagamot po at hindi, sa tingin mo, hindi malala ang mga mikrobyo nila, and it will be the IV form of your simpler beta-lactams or your combination, the ampicillin-sulbactam, for example, and dual therapy pa rin ho tayo. We still make sure that we have a macrolide on board, or if you can't really use a macrolide, the fluoroquinolone can be an alternative to that, but we never usually treat with monotherapy when we confine our patients with CAP, because nakita po na it really improves mortality among our patients if we do dual therapy. Tapos, itong high-risk CAP, ito yung nasa ICU po. No? So, hindi naman porke nasa ICU na bobombahan mo na lahat ng antibiotics. Actually not. You still have to discern whether your patient is at risk to have multi-drug resistant organisms. And if they don't have that risk and medyo malala lang talaga yung pneumonia nila, we still have the same kind of treatment as our moderate risk na nasa ward lang na pasyente, no? And still, we make sure that there is dual therapy there. So ngayon, sino yung binibigyan na natin yung matatapang na mga antibiotics? When we say matapang, ibig sabihin we want to cover the bad gram-negative organisms like Pseudomonas or your ESBL-producing organisms or, for example, your methicillin-resistant Staph aureus. Kailan po natin to iisipin? So iisipin po natin ito kapag nandito itong mga kondisyon na to. No? Kung merong IV antibiotic therapy for the past 90 days, then we consider methicillin-resistant staph and we give the corresponding antibiotic. Or if there is a possibility that there might be Pseudomonas at sino tong prone na magkaroon ng Pseudomonas, kung meron silang underlying bronchopulmonary disease, dito hindi nilagay pero dati iniisip din namin pag may oral steroids on board, at risk din sila and prior tracheostomy. And for yung overall din risk now of those bad microbes, then again, prior IV antibiotic therapy would be the predisposing things. So ngayon, ang tanong, kayo ba ay nagbibigay ng antibiotic sa lahat ng COVID-19 pasyente nyo ina-admit sa ospital? No? Well, no one can fault you for doing that because you're considering them to be in the CAP syndrome, right? So, but there are now many advocates now for us to discern a little bit better. Kasi it just happens in 19% of our patients when they come in. So if you're really, really sure na COVID lang talaga to, na walang underlying na bacterial then you can be brave enough. As you can see here, although weak lang yung recommendation nila, not to give antibiotics at the start. And what do we see the ID people doing? Kilala nyo si procalcitonin? Ito po yung blood biomarker na nauuso po ngayon, lalo na ngayon sa COVID. Kasi minsan, ito po yung pang-discern namin kung meron bang bacterial infection or not. So kung ano siya, mataas ang value, it may be an indicator that it's more bacterial than viral, but all the guidelines will tell us do not do so. No? So hindi natin i-base kung may bacterial or viral just based on a single biomarker alone. We do still have to have an overall clinical assessment. Napakahaba yata nun. Thank you.
Sige. Okay. Ahmad, yung sa mga nasabi ni doktora, no, ng nating dalawang doktora, available naman itong mga empiric na gamot sa inyong lugar. Kasi ata isang issue din yun, no? Sinasabi nila maraming supply ang DOH. Pero itong supply po ba nakakarating sa lugar ninyo? Available ba itong mga gamot na to?
Yes po. May available naman po. At least
naman. So nasabi ni doktora, no, yung about sa COVID, tumataas ba ang mga ang mga kaso ninyo ng COVID sa inyong lugar? Yung mga sa mga kasama mo, ano yung mga sabi nila sa sa condition ng kanilang lugar?
Assign po ako sa Sulu. For the past few months, bumababa yung pero parang this month, parang bumabalik na naman siya, tumataas ulit. Pero hindi naman po kasi grabe na dito sa NCR.
Okay. So mukhang ang COVID is mas populated na areas pa rin ng Philippines.
Pero yun din. Kahit sa rural setting, it's always a challenge when to decide kung COVID nga ba ito or pneumonia. Especially with the absence of like RT-PCR, wala kaming laboratory doon mismo. Pinapadala ko po yan sa Zamboanga, which is 8 hours away pa by boat. So minsan nadidelay kapag may mga bagyo, hindi maka yung barko, mas lalo madidelay pa yung decision making. So the patient could stay as a suspect pa rin, lalo kapag severe. Dito na namin nalalaman ko yung doon pa rin sa decision making.
Amat, siguro if I can pick up on that comment, although I'm sure mas marami pa tayong pag-uusapan tungkol sa COVID in a little bit. Naalala ko kasi yung sitwasyon, even in PGH, na nagsimula yung pandemic. Kasi although urban nga yung setting, hindi naman naging university available yung RT-PCR. At may panahon nung simula na parang 3 araw, 4 na araw bago mo makuha yung resulta. No? So we were very dependent at that time on utilizing the imaging studies to help us distinguish whether COVID was really supposed to be a differential for the case. Kasi nung panahon din na yon, syempre, hindi pa uso yung clustering ng cases na hallmark din ng COVID ngayon. Kasi at least in pediatrics, no, ang tinatanong namin karaniwan, yun bang bata, may kasama sa bahay, may adult na nagkasakit din, at kung nagkaroon sila ng respiratory tract infection within the household, malamang sa hindi, pati yung bata, apektado yan, and COVID positive din. Pero anyway, I guess my point is, in settings where the RT-PCR may not be as readily available, the imaging findings can be helpful kung yun lang at yun ang pwede nating gamiting basis.
Thank you, Doc.
Any additional comments, Dr. Fernandez?
Yeah, so I remember that time, Anna, my gosh, the patient would be there for 5 days. Wala pa tayong diagnosis, no? So, nangyari during that time sa mga big centers, ina-abuse din ng CT scan. So, kasi mahirap nga minsan makita sa x-ray. So, magpapa-CT scan para kung makita yung GGOs, no? So, there are many studies, of course, saying na please don't do that. Kaya, my gosh, kung forced to good nga at that time. So there was also a lot of antimicrobial use during also that time.
So, sige, later na lang siguro sa open forum. We'll pick up on that later. Since we know how to treat pneumonia, we know how to diagnose and classify pneumonia as to their severity, how can we prevent pneumonia? Are there measures which we can offer our patients so that we can prevent the occurrence or incidence of pneumonia for our patients?
Sige, simulan ko ulit, Jessie. So for pediatrics, talagang matunog na matunog yung intervention about vaccination kasi alam naman natin na marami dun sa mga pathogens na problematic for kids are vaccine preventable. And although most of our focus has been on strep pneumo recently, no, huwag nating kakalimutan that Hib, which has long been available in our vaccination program, is also a significant cause of pneumonia in kids and needs to be addressed using the very effective vaccines that we already have. Now, karaniwan, no, nasa forefront ng ating pag-iisip yung strep and Hib, pero pertussis also causes pneumonia, measles also causes pneumonia, at itong dalawang vaccine preventable diseases na to na napakatagal na nga na nasa programa natin hindi rin dapat natin baliwalain. Siguro what I'd like to point out also, no, is that unfortunately the COVID pandemic has also had a very significant fallout for the pediatric vaccination program. And naalala ko nung nagsisimula pa lang tayo last year, after the first quarter, ang coverage was less than 15%. So, parang ako, ang word na nasa isip ko nakakapangilabot. Kasi parang nag-aantay talaga ng disaster na mangyari and magkakaroon na mabilis na pagkalat ng sakit. So at the conclusion of 2020, I was told that umabot tayo ng mga 60-something% na coverage. No? So malayong-malayo pa rin dun sa ating tina-target na 90. Even with that emphasis on the immunization of children, and we know already that all of these vaccines are available in the program. No? Even the pneumococcal conjugate vaccine is supposed to be in the program for most of the country, save for regions 3, 4A and NCR. Yung uptake nga ang ating issue ngayon dahil access is a problem. Yung ating healthcare workers, attention is divided. Karamihan sila na divert sa COVID response. And yung logistics is also an issue. Now, aside from vaccinations, meron ding role ang pag-control ng environmental factors. So, it's been said that parental smoking can be a very significant risk factor for a child's susceptibility to pneumonia, as well as indoor air pollution caused by cooking with biofuels or heating using biofuels. So, maaring hindi natin ina-associate ito with pneumonia, but it's something that is preventable, particularly for households engaging in this practice. Yung isa pa is living in crowded homes, and this is very easy to understand. Siyempre, dun sa mga setting na ganyan, pagka merong isa nagkaroon ng ubot-sipon, madaling-madaling pumalat. And of course, we know that kids are quite susceptible as their immune systems are still just learning how to fight off these bugs. Meron ding a risk yung mga malnourished or undernourished kids, particularly infants who are not exclusively breastfed, and also those with comorbidities, particularly those with symptomatic HIV, and also those who currently have measles. They have an increased risk of contracting pneumonia. So itong mga risk factors na to, kayang-kayang i-address at makakabawas talaga dun sa likelihood of getting pneumonia kung pinansin din natin ng maayos itong mga problema to. Lenny?
Ana, I would like to ask na at this point kasi hindi ko talaga mapigilan. Do you think na nagkaroon ng implication yung kakulangan natin ng pag-vaccinate ng mga kids at the earlier part of the pandemic to what's happening now? Is there an increase in the bacterial community-acquired pneumonia, for example?
So is this with reference, Lenny, to the higher rates of COVID in kids?
Yeah. Not really sa COVID, pero even the bacterial infections, kung hindi sila protected, mas madami bang respiratory tract infections sa non-COVID din ngayon?
Well, napansin din namin yan. Bago pa kasi nagkaroon ng surge, particularly in NCR, dumami na talaga yung mga pasyente naming merong respiratory tract complaints. And mahirap sabihin hindi kasi nakita talaga natin yung significant drop ng vaccination rates. Although, if we follow the distribution of disease, or rather consults na lang, siguro at least for our single center experience in the Philippine General Hospital, pagka medyo pumapalo na yung tag-ulan, marami ng pneumonia. And this year was not an exception. Ang nakakalungkot, parang nagkasunuran sila. Nagkaroon na nga tayo ng problema with pneumonia. Nagsimula nang mapuno yung mga wards kasi dumadami na yung may respiratory distress. Tapos dumating pa yung COVID, umapaw talaga.
Ay nako, sana makaahon tayo nito lahat, no?
That's right.
So, yeah. So one way also to protect yourselves would be the same things here, the measures here are the same din sa mga bata, no? And we cannot overemphasize the need for vaccination. Sa adults naman po, influenza vaccine and our pneumococcal vaccine are the ones that are important to prevent pneumonia. So bakit related po sila, no? So with having influenza infection, that also predisposes you to having bacterial community-acquired pneumonia. So it is really routinely recommended yung pagbigay din ng influenza vaccine among adults, even among the elderly, kahit less yung mortality benefit among the elderly with influenza vaccine, it can lessen the occurrence of influenza. And even among pregnant women po, no, they can receive the influenza vaccine on the 2nd to 3rd trimester. No, ngayon, marami akong pasyente nagsasabi, siguro ikaw din, Jessie, Doc, pneumococcal vaccine ako, bakit ako nagka-pneumonia pa? So, syempre, mega explain tayo na strep pneumonia is just one of our microbes that can cause CAP. But nevertheless, it's still worthwhile to do our pneumococcal vaccine. And you know that we have 2 now that are available. So, hiniram na rin natin yung conjugate vaccine ng mga bata. Ginagamit na rin po natin sa adult po siya. So ito po yung nakita nilang most common na serotypes ng strep pneumonia dito sa left side ng slide. Kaya lang yung in-encircle ko dito po, it would show that at least the most common serotypes of strep pneumoniae that's present here in the Philippines are covered also by our 2 kinds of vaccines. That would be the polysaccharide and the conjugate. Kaya lang, alam po natin, so sa siyensya po ngayon, we borrowed that also from the kids. Now, with our conjugate pneumococcal vaccine, it is able now to have a more lasting memory kasi po yung T-cell po ay na-stimulate din. So that's why longer yung action, more siya yung immunogenicity compared to our polysaccharide vaccine. So ang recommendation na po ngayon sana for adults, then we do give preferably the PCV13, but it is still all right to give the polysaccharide kind of vaccine following ito pong scheduling dito. So it benefits our pneumococcal vaccine, both immunocompetent adults, even if they're elderly or not. And especially, syempre, yung merong mga comorbidities po. Among pregnant women, ang allowed po ay yung polysaccharide vaccine lang po. Wala pa kasing studies on the conjugate vaccine for the pregnant women. So that's all for the vaccination for adults.
Ma'am, sa COVID ngayon, no, isa sa madalas na tinatanong ng pasyente is kung kailan pwedeng ibigay yung flu at saka pneumonia matapos bigyan sila ng COVID vaccine. Kasi maraming doktor inuuna muna yung COVID vaccine kasi wala daw tayong control sa availability ng COVID vaccine. So pina-prioritize nila yon sa patient. So medyo na-delay yung pagbibigay ng flu at pneumonia vaccine. How soon can we give these vaccines to our patient after a COVID vaccine?
So, ang recommendation ni Ana from the vaccine group, the ones who are in charge of the national COVID vaccine program, in 2 weeks sanang pagitan. Pero Ana, meron bang mga exceptions sa ganon?
Yeah, so actually, kung medyo nagbabasa din tayo
Naka-mute ka yata, Ana.
I'm sorry, can you hear me now? Yan. So, guidelines coming from abroad actually started off that way, yung 2-week interval between doses. And the concern really that they were addressing at that time was yung confusion between possible adverse events following immunization kung nakatanggap ka ng, let's say, flu or pneumococcal and COVID all at the same time. And actually, walang safety or efficacy issues naman na tinutukoy kasi all of the vaccines that we're using for these pathogens are all inactivated. Alam naman natin na walang interference pag inactivated vaccines ang pinag-uusapan. So in cases where it's very, very urgent already for the patient to receive, for example, their flu vaccine, kasi sobrang high risk, hindi mo ma-attain na kahit isang araw ay hindi siya pag-antayin mo siya, pwede naman. Pero ang wording ngayon ng ating local recommendation is shared decision making. No? So, again, intindihin natin yung perspective. Iniiwasan lang natin yung confusion. Ayaw nating malito kung may mangyari, kung sinong bakuna ang pagbibintangan natin. And walang problema with safety and efficacy. So kung kailangan, pwedeng pagsabayin. Pero mas madali, mas makakahinga ka ng maluwag kung pag binukod mo siya ng 2 linggo. And also siguro dagdag ko na lang din, kasi minsan may naririnig ako yung mga nakakagat ng aso or nagkakaroon ng mga injury na kailangan ng tetanus vaccines tapos nag-aantay pa sila ng 2 linggo. Di counted yun, emergency, kaya kailangan na ngayon.
At least nalilawan na tayo doon, So kinakailangan mabigay siya, Kung kinakailangan ibigay agad. Kung makakaantay, 2 linggo. Okay. So Ahmad, may mga tanong ka pa ba? Bago natin ibukas ang sa mga questions ng mga iba nating kasama.
I think sa mga questions po, parang wala na, mukhang magiging open forum. Pero parang I would like to parang sa last discussion natin on prevention, parang nakikita natin yung importance ng role ng public health dito, lalo ng ating mga RHUs. So, even though at the presence ng COVID, kailangan tuloy pa rin ang ating health education sa ating community, lalo na sa preventive measures, which is mas gusto natin yung ma-prevent kasi naman darating yung patient na severe na. So, that's a good input na nakuha for this discussion. So, I think it's now time for us to proceed na lang po sa ating open forum. Dr. Jessie, I think.
We now proceed to the open forum, to be moderated by Dr. Eileen David Wang and Dr. Ahmad Sampang Musahari. Dr. Eileen David Wang is an Associate Professor of the Division of Pulmonary Medicine, Department of Medicine in UPPGH. Joining Dr. David Wang in the discussion is Dr. Ahmad Sampang Musahari. Dr. Musahari is a Medical Officer 3 in Sulu Sanitarium. Let me now call on Dr. David Wang and Dr. Musahari to lead the discussion in this focus session.
Thank you very much and good afternoon. Congratulations sa mga organizers, ang dami nating attendees. And I have to say, we're so fortunate to have Dr. Fernandez and Dr. Ong Lim. Alam niyo po, hindi lang po sila magaling na speakers, in-demand speakers, they are also dedicated frontliners po nandun po sila. And I have to say, they influence health policy making dito sa Pilipinas. So, swerte po tayo, they are with us. So, yung very first question, and na-cover nyo na actually ito, pero let's reiterate yung information. In this time of the pandemic, with COVID pneumonia as a consideration, how will you differentiate COVID and non-COVID based on mga clinical decisions alone and in the context of telemedicine consultation? That's one. And number two, kung may chest x-ray nga, can you differentiate COVID and non-COVID pneumonia? Siguro, Lenny muna.
Sa adult, in terms of differentiating physical exam, medyo mahirap talaga. Lalo na nga na hindi tayo nakaka-auscultate at this point in time. Sa telemedicine, we look actually, it's also really difficult, no? So, ang problem kasi natin is the danger of missing out on COVID. So parang everyone is suspect to have COVID if they present with an acute respiratory illness, and then we try to rule out the others. So that's the safer way to do it. So suspect anyone presenting with a cough, fever, and all those things to have possible COVID. In terms now of the x-ray, we do like to see yung lower lung field na infiltrates na medyo mga tinatawag nating interstitial infiltrates at lalo na nasa periphery. Then we suspect that that's a viral kind of pneumonia, and most likely in our present pandemic situation, that would be COVID. But again, we are always told not to rely on that because again, the safer way is to consider everybody as possible COVID and then you rule it out.
Lenny, you mentioned kanina GGOs. Can you tell us what you meant by GGOs?
So these would be the small dot-like things that we see on X-ray. So compared to our the bacterial, for example, or a common knowledge of pneumonia on X-ray na lobar yung consolidation natin, di ba, na may nakikita pa nating mga air bronchograms. So sila, nandoon po yun sa periphery nga at mga dot-like structures yan na dispersed throughout, usually, as I mentioned, sa lower lung field fields.
Oh, I think ground glass opacities, no? Yung ibig nating sabihin sa mga GGOs, usually nasa periphery. Ana, sa PIDS naman, anong marirecommend mo? We can't hear you, Ana.
I'm so sorry. So what we've been doing so far in pediatrics is really rely a lot on the history of exposure. It's really because kids have not been out for almost 2 years and their exposures have primarily been to the adults in their household. So once you get a consult from a family that tells you, ay may sakit yung anak ko, merong lagnat, actually kahit fever lang your antenna starts buzzing and you think, okay, can this be COVID? And the next question I will ask is, may nagkasakit ba sa bahay? Once they tell me meron then I have to say you have to test because this constellation of symptoms, even if we're primarily looking for cough or respiratory illness, can present very subtly in kids. They can just present with fever and that's it, or fever and abdominal pain, or fever and diarrhea, and fever and vomiting. So pwedeng primarily GI symptoms. So I guess the bottom line for us in pediatrics is we ask about the exposure history. And if there's something going on in the family, we're very suspicious that could be COVID.
So take-home message po, in this time of the pandemic, suspect COVID until proven otherwise.
Yes, walang mawawala kung praning.
Yes, so isolate nyo na po kagad yung mga pasyente ninyo. Yes. Ahmad, next question please. Ahmad, are you there?
I'm here.
So,
yeah, his video has frozen.
The next question is already answered by our presenters earlier. So when we give the next question, because we have limited time, it's a question for what is your stand in the use of air purifiers in preventing pneumonia in COVID? To our both presenters.
Okay. Can I just start, Lenny?
Yes.
Yeah. So sa infection control kasi, ang principle na gusto nating sundin is to improve ventilation. And I guess that's the objective also of using these air purifiers. Now, we know that purifiers, of course, have a cost. And when you can achieve good ventilation by just using simple methods such as opening your doors and windows, then why would you have to um, um, spend extra when the objective is achieved? So I guess I would classify that as a nice to have, but not essential. But also remind people that when they talk about air purifiers, it's not one size fits all and not everything is equal. You need to be able to ensure that you're using the correct filters, no? So dapat HEPA filter siya because otherwise you won't be able to get the viruses off of the air. Then you also need ventilation, otherwise you don't have the air exchange that's necessary to purify the air. So maraming precautions using these air purifiers, quote unquote.
Yeah, I would have the same stand as Anna.
So mukhang one last question na raw tayo, Ahmad. So siguro I'll cover, tanungin ulit natin, yung role ng PCV13 at saka PPV polysaccharide vaccine 23, Lenny. Ano ba yung timing at saka yung boosting na yan? Pakituro mo naman ulit sa adults. Tapos kay Anna later on, when do you give PCV13 and when do you give PPV23 sa mga bata? Lenny, ikaw muna.
So for the adults, we do prefer to give the PCV13, and then we follow a year after with our polysaccharide vaccine. And then
so we give both, no?
Yes, we give both.
Sige. Pero I think sa immunocompromised, 8 weeks yata yung duration ng dalawa, no?
Yes, it can be earlier for our immunocompromised patients.
How about yung boosting ng polysaccharide vaccine?
With that, so we usually, after the 1 year na pagbigay ng polysaccharide na vaccine, there's no need na for most immunocompetent patients unless mag-change na naman ang guidelines. So what's new right now, Dr. Rawang?
Oo. So sa PCV13, once lang yan, lifetime. Tapos yung polysaccharide vaccine, booster after 5 years. Hindi yun every 5 years. It's a booster after 5 years. Kung umabot yung pasyente ng after age 65, pwede siyang bigyan ng a third booster. Ito yung latest CDC January 2021 guidelines. How about sa bata, Ana?
For kids, it's a little simpler, no? Kasi we understand naman that in the program, in our national program and in our recommendations, all children are supposed to be receiving pneumococcal vaccines. And the preference is also to use conjugate because this not only provides protection against the serotypes of interest that are circulating in the community, but also provides or eradicates nasal carriage, which is important for ensuring herd immunity. So, ang ginagamit talaga is PCV. And only in exceptional circumstances will you be using your polysaccharide vaccine. So typically in the past, who cannot afford yung patient kasi may kamahalan yung PCV. Kaso nung nagkaroon na kasi ng PCV sa program, wala na talagang excuse. No? Everybody could access it, libre nga. And we're using the same products in the private setting as well as in the public program. So we only provide it for children under the age of 5, or rather 5 and below. It's a series of 4 doses, 3 primary plus 1 booster. We start at the age of 6 weeks. And then the only instance in pediatrics where you would include coverage with PPSB on top of the PCV is for immunocompromised individuals or those with chronic illness, because you want to benefit not just from the long-lasting protection that PCV provides, but also from the breadth of protection that your polysaccharide vaccines is able to give with more serotypes. The interval for pediatrics is more forgiving, 8 weeks ang standard namin from the PCV series to the PPSB.
Sige. Ang daming tanong sa Q&A box. Unfortunately, overtime tayo. So I hope masagot ng ating speakers sa Q&A box yung mga tanong. Ahmad, shall we close this? So sorry, we don't have as much time for the other questions. Back to you, Ahmad.
Yes po. Thank you po sa ating speakers, Dr. Ana Ongling and Dr. Leonardo Fernandez for the wonderful lectures. And sa aking co-moderator, Dr. Aileen Wang. And to all the participants, thank you.
Thank you.
Thank you, speakers and moderators. We would like to award the Certificate of Appreciation to Dr. Anna Lisa Ong Lim for her invaluable contribution as a resource speaker on the topic on clinical pearls and pneumonia management in pediatric patients during the UP College of Medicine Grand Scientific Symposium. This Certificate of Appreciation is given to Dr. Lenora Fernandez for her invaluable contribution as a resource speaker on the topic on clinical pearls and pneumonia management in adult patients during the UP College of Medicine Grand Scientific Symposium.
We would also like to award the Certificate of Recognition to Dr. Eileen David Wang and Dr. Ahmad Sampang Musahari for their contribution as moderators for this focus section on pulmonology, given this 22nd day of September 2021.
We would again like to thank our sponsors for their support in this year's University of the Philippines College of Medicine Grand Scientific Symposium. Please stay for a third focus session on diabetes, which will begin after the industry-sponsored lecture.
Good day. On behalf of AIM Menarini Philippines, we welcome you to this industry-sponsored symposium. If at any time you have any questions for our speaker, please type it in the Q&A box and we will address them during the Q&A session. It is my privilege to introduce our moderator this afternoon, Dr. Veronica Magnaye. Dr. Magnaye is a fellow of the Philippine Society of Otolaryngology Head and Neck Surgery. She is the past vice president of the Philippine Society of Otolaryngology Head and Neck Surgery of the Southern Mindanao chapter, the past secretary of the University of the Philippines Philippine General Hospital Alumni Association, the program director of the Mindanao Neonatal Hearing Screen Program, Club to Club project of the Kota Club of Davao. She is the Assistant Medical Director of the San Pedro Hospital of Davao City and is the Chief Executive Officer of the Integrated Clinics of Otolaryngology Head and Neck Surgery Incorporated and is the past Treasurer of the UPMAS Davao chapter. Please help me welcome Dr. Veronica Magnaye.
Good afternoon, everyone. Welcome to the next lecture sponsored by Menarini. This afternoon, our lecture is entitled Solving the Nasal Allergy Puzzle. May I introduce to you our guest speaker, Dr. Christine Del Monte Dayanghirang. Dr. Dayanghirang graduated from the UP College of Medicine in 1995. She also had her otolaryngology head and neck surgery training at the UP-PGH. Dr. Dayanghirang is the former chair of the Department of Otolaryngology, Head and Neck Surgery of Davao Doctors Hospital. She is presently an associate professor of the Davao Medical School Foundation and the chairman of the Department of Otolaryngology, Head and Neck Surgery of Southern Philippines Medical Center. Ladies and gentlemen, friends, help me welcome Dr. Christine Del Monte Dayanghirang.
Thank you for that introduction. Thank you, Menarini Philippines, for inviting me to be a speaker for tonight. Before we start this lecture, I would like to congratulate UP College of Medicine and the UP Medical Association of Davao for the success of their Grand Scientific Symposium 2021. Good evening, everyone. I would like to share with you tonight new information on how to manage our allergic rhinitis patients. Is our standard therapy enough? Our oral antihistamines, our intranasal corticosteroids, are they enough? Or can we add more? Is there something more that we can add to the allergic rhinitis armamentarium? Solving the nasal allergy puzzle. We will try to solve that tonight. Okay. So presented here is a case of a 63-year-old male complaining of sneezing, watery rhinorrhea, nasal obstruction, and eyes pruritus or itchiness. He has both hypertension and diabetes controlled with medication. So what do you think is the primary feature for this case that needs to be addressed before we plan our management of his allergic rhinitis? Is it his age? Is it the presence of hypertension, the comorbidities? Is it the severity of the nasal signs and symptoms? I believe that we can answer this primary question if we know the unique characteristics of rhinitis in the elderly. First, we have the physiologic age-related nasal changes that make our adult patients more susceptible to rhinitis. We have their presence of comorbidities, the immunosenescence, which is the immunity dysfunction as we age. We also have the status of polypharmacy, which can truly impact compliance, and the possible adverse drug reactions for these multiple medications. Polypharmacy. In the US, they studied that more than 50% of prescriptions prescribed were given to the 60 years old and above patients, and that 1 of 6 hospital admissions in this age group resulted from adverse drug reactions because of the multiple medications that they take. What do you think is the most ideal characteristics of antihistamine for this particular patient? For the elderly, the ideal antihistamine should have high H1 receptor selectivity, should not require dose adjustments, especially for those patients with hepatic and renal impairment. In 2017, published in the Asian Clinical Molecular Allergy, they presented this treatment algorithm for the selection of the proper antihistamine in the treatment of allergic rhinitis. So in this slide, you can see there are 2 major groups of patients from age 12 to 65 and the elderly. So for these groups of patients, they subdivided these 2 into those without complications or comorbidities and those with comorbidities. So as you can see for this area, if you can see my cursor, as you can see, for these patients of allergic rhinitis without comorbidities, we have a lot of choices for our oral antihistamines. We have bilastine, fexofenadine, levocetirizine, and the others. In contrast, for this side of the slide, we have these allergic rhinitis patients with comorbidities. We only have a limited choice of antihistamines. Furthermore, for this group of patients who require high level of concentration for their daily activities, the group recommended bilastine as the antihistamine of choice for this group of patients. So, as we all know, we always tell our patients in the management of allergic rhinitis, first is the avoidance of allergen, and we take time to educate these patients on how to do this. We have, for the pharmacotherapy, we have the oral antihistamines, the intranasal corticosteroids. We also should present to them the option of allergen immunotherapy. So these compose the puzzles for allergic rhinitis. In the attempt of improving the allergic rhinitis treatment, recent pharmacological developments has been towards the use of barrier protection measures by the application of topical nasal cellulose powders. So these powders were shown and were studied and shown to have very good effects in the treatment of allergic rhinitis. In particular, this is the HPNC, or the hydroxypropyl methylcellulose formulation of a powder nasal spray. Several studies have shown its effectivity against allergic rhinitis. Let's take a look at the normal or the epithelial barrier dysfunction in allergic rhinitis. Remember, in allergic rhinitis patients, they have this state of chronic inflammatory state of the nasal cavity. Thus, their epithelial barrier is now dysfunctional. In a normal epithelium of the nose, We have all this ciliated epithelium, this mucous gel layer, and it has low permeability, and they prevent interaction or diffusion of the allergen into the nasal mucosa, and they have this normal ciliary flow. Whereas for our allergic rhinitis patient with a chronic inflammatory state, we have high permeability. There is tissue penetration of the allergens, of the inhaled allergens, and thus the inflammatory response is triggered. So there is distinct difference between a normal and an abnormal epithelial dose for allergic rhinitis patients. HPMC is a topical powder nasal spray, is the newest therapeutic options for allergic rhinitis. It is composed of microcrystalline powders, which, when sprayed into the nose, HPMC powder is sprayed into the nose, automatically as it comes in contact with the nasal mucosa, it turns into a gel. And this gel forms a layer over the mucosa, creating a barrier for the inhaled allergens. So in this diagram, this one is without HPMC. The inhaled allergens can seep through and diffuse into the mucosa, triggering the inflammatory reaction. Whereas for those nasal epithelium with HPMC, there is a distinct gel layer on top of the epithelium of the mucosa, which adds another barrier to prevent diffusion of these allergens, triggering the inflammatory response. Another study investigated the diffusion of the house dust mite allergen through various barriers. We have the agar, the Vaseline, and the HPMC gel. And they found out that HPMC delays the diffusion in vitro of the allergen. So the red line is the diffusion rate of the allergen through the barrier of HPMC compared to the fast diffusion of the allergen through the agar and the without barrier. HPMC is further studied and showed that it can increase allergen threshold fourfold. So that means there is a need for a higher volume of nasal allergens before it can create inflammatory reactions of the allergic rhinitis. It also significantly reduced the allergic rhinitis signs and symptoms in both allergic rhinitis and allergic asthma for children, as published by in American Journal of Rhinology and Allergy. In this study, they group all the allergic rhinitis patients. They group into two. The first group was given with standard therapy of oral antihistamines and or intranasal corticosteroid, as the case may be. So as we all know, the nasal signs and symptoms given standard therapy of allergic rhinitis is significantly reduced from before treatment. As compared to the second group, where patients were given HPMC on top of the standard therapy of oral antihistamines and intranasal corticosteroid, they found a further decrease in the nasal signs and symptoms, significant further decrease in the nasal signs and symptoms of allergic rhinitis. It also optimizes quality of life in combination of our standard therapy. HPMC is made from the cellulose, a natural product. It has no known side effects, and it can safely be given for children, adults, and even pregnant women. And so, for our allergic rhinitis patients, we do not only limit ourselves in patient education and allergen avoidance. We should also know as clinicians which anti-allergy is best for our particular patient, especially for those with comorbidities, for which the treatment algorithm presented recommend bilacine as the ideal antihistamine for this subgroup of allergic rhinitis patients. And now we were able to introduce to you a new product, a topical nasal spray of HPMC, hydroxypropyl methylcellulose, as an effective natural barrier to add in our allergic rhinitis treatment armamentarium. It significantly reduces the nasal symptom scores of our patients, and when combined with our standard therapy, it enhances the effect of our oral antihistamines and our intranasal corticosteroids, providing better quality of life. HPNC, as they presented, is safe and can be given to children over 18 months, adults, pregnant, and breastfeeding women. So now we have been introduced to this new product, which I hope completes the puzzle for the treatment of allergic rhinitis. I think that's my last slide. Okay, so thank you everyone and good evening.
Good evening, everyone. So we're going now to open the floor for questions for Dr. Del Monte Dayanghirang. We just have one or two quick questions. What is the HPMC powder marketed brand, Doctora?
Hello, good evening, everyone. Thank you, Dr. Magnaye. The brand name, it's Quix, Quixx. It's already available.
Right. Ito ba, one last question siguro, because we're really, in the interest of time, we don't have much time. We only have one last question. If we give Quix with nasal steroids, Doctora, what is the order of spraying into the nose?
Okay, so first of all, you make sure for all our patients, first of all, you make sure that your nose is clear of the mucus. So you blow your nose gently, and then you spray in your intranasal corticosteroids, and then after which you spray in your Quix.
All right. We will end our Q&A there. We'll keep it short and sweet. It's 6:01. Thank you very much. Dr. Mata will be very glad that we really kept it short and sweet. Thank you very much, everyone. Thank you, Dr.
Thank you also, Menarini. Thank you also, UPGSS, and thank you, Menarini.
Thank you. Thank you.
Again, we would like to thank our speaker, Dr. Christine Dayanghirang, our moderator, Dr. Veronica Magnaye, as well as all our attendees. Thank you for your kind attention, and congratulations to the organizers and officers of the UPMAS from A. Menarini, Philippines. Thank you and good afternoon.
Using Quix nasal spray is simple and easy. Start by blowing your nose to clear the nasal passage. Remove the cap and shake the bottle from side to side. Do a test spray to check the pressure required for the ideal dose. Just a 10 to 15 centimeter plume of powder. If you find the bottle is too thick to squeeze with one hand, use both. Place the nozzle off the bottle just inside your nose. Apply 1 or 2 sprays into each nostril. Inhale gently while squeezing the bottle. Don't inhale deeply. Quix should be taken 2 to 3 times per day and reuse it each time you blow your nose.
We now proceed to our third focus session, which is on diabetes. The chair of this session is Dr. Diane Bernardo, Davao's very own homegrown endocrinology expert.
Good afternoon, everybody. Welcome to the session on diabetes and CKD. There are around 3.9 million Filipinos living with diabetes, and even more are projected to have this condition in the years to come. At present, it is already the top cause of chronic kidney disease leading to dialysis among Filipinos. Now, how has the management and approach to diagnosis of diabetes changed over the years? When do we really screen for diabetes? And what tests should we really use to diagnose diabetes? What medications can we give our patients, especially once kidney involvement already sets in? Let us all listen and learn from our esteemed experts.
Our first speaker for this session is Dr. Cecilia Jimeno. Dr. Jimeno is from UPCM class of 1994. She finished her residency in internal medicine and fellowship in endocrinology, diabetes, and metabolism in Philippine General Hospital. She is currently the chair of the UP Department of Pharmacology and Toxicology, a professor under the UPPGH section of endocrinology, diabetes, and metabolism, and she is also an active consultant at the San Juan de Dios Hospital. Aside from being active in the clinics and the academe, Dr. Jimeno is also a panel chair for the UP Research Ethics Board, as well as the vice chair for research for the UPPGH Department of Medicine. Let us now give our full attention to Dr. Cecilia Jimeno as she teaches us the standard of care in type 2 diabetes mellitus.
Thank you very much for the kind introduction. My topic is Bullseye, Standards of Care in Type 2 Diabetes. I've been given 5 objectives that I've reduced to 4, and that's first to talk about tests used for the diagnosis of type 2 diabetes, to analyze the approach in using the different options for treatment, including treatment goals and monitoring treatment responses, and finally, to discuss complications, including epidemiology, prevention, and treatment. We all have seen a slide similar to this that talks about the epidemiology of diabetes in the Philippines. We are now at around 8% prevalence of diabetes, and this is probably an underestimate because this is only based on one determination of fasting blood glucose. We also know already that in the Philippines, screening is recommended even if asymptomatic among relatively healthy people for 40 years old and above, and younger if you have one or more risk factors for diabetes, including history of pre-diabetes, a first-degree relative with type 2 diabetes, women with history of GDM or PCOS, those who are overweight and obese, and those with one or more components of the metabolic syndrome, including hypertension, low serum HDL, elevated triglyceride, and also the presence of physical examination finding of acanthosis nigricans. Screening is also recommended among those with previous ASCVD, among those with schizophrenia, especially on medications, and those with tuberculosis or systemic rheumatologic disorders such as psoriasis and SLE. So we'll begin with the first bullet point, how to use the different diagnostic tests for diabetes. Now, in the previous Unite for Diabetes practice guideline, we already recommended FPG, the random plasma glucose, and the 75-gram OGTT. But now the A1C is also recommended by the Philippine, the periodic health examination. And how it's written is that it is suggested to use it as screening for type 2 diabetes. So again, just to reprise, the diagnostic criteria for diabetes is an FPG more than or equal to 126, a random blood glucose of 200 and above, and the 2-hour plasma glucose post-load also of 200 and above. So that's easy to memorize. It's 711, no? Multiplied by 18. And for the A1C, it's 6.5% and above. When any of these 3 tests are positive in a symptomatic patient, then that's already diabetes, no? And that's the presence of 3 Ps, polyuria, polydipsia, polyphagia, and weight loss. In screening among those who are asymptomatic, the presence of any 2, no? Any combination of the 2 is diagnostic of diabetes. Now, how to use each test? The FPG is the preferred test for screening due to its wide availability, lower cost, and better reproducibility. When a patient has a previous diagnosis of pre-diabetes, such as IFG or IGT, then the 75-gram OGTT is preferred. And of course, for those who are symptomatic with the 3 Ps, confirmatory is a random blood glucose, but an FPG can also be done. So FPG is preferred because it's simple, it's standard, it's low cost, it's readily available. A 75-gram OGTT is preferred in previous pre-diabetes or a previous diagnosis of ASCVD or those who are at high risk of CVD, and for persons with metabolic syndrome. And of course, for screening for GDM, we recommend the modified 75-gram OGTT among pregnant women. Now, if you're going to use the A1C, there are some caveats. Please use a test that has been standardized according to the National Glycosylation Standardization Program, Glycosylated Hemoglobin Standardization Program of the US, or the DCCT. So you can check that with your laboratory if they're using a standard test. And when there's a marked discordance between the A1C and plasma glucose levels, then of course this raises the possibility of an A1C assay interference, and therefore just use the plasma blood glucose. So when can false results come in? These are typically whenever there are problems with the turnover of your red blood cells, such as in hemoglobinopathy, such as sickle cell disease, pregnancy, the presence of G6PD deficiency, HIV, hemodialysis, and even the use of erythropoietin therapy, where only the plasma blood glucose criteria should then be used. The practical approach is actually to do both the A1C and the FBS together, because you not only diagnose the diabetes, but it can also guide therapy, because the A1C can be used to stratify the level of glycemic control. And so we go to the next bullet point, which is to talk about the approach to using different options of treatment and the treatment goals. So general approach to therapy is to advise medical nutrition therapy for all patients on first diagnosis, advise on increased physical activity and exercise, and weight loss strategies if overweight or obese. Most newly diagnosed persons will still need drug therapy, even on first diagnosis, and treatment decisions will be based on the stratification of the patient according to glycemic levels, as well as the presence or absence of certain patient circumstances. The other treatment decision is whether to use injectable therapy or not. In the Philippines, based on the Unite for Diabetes guideline, which we are currently actually revising, if you are newly diagnosed and your blood sugar is elevated, an FBS more than or equal to 200, or an A1C of more than 9, then there is an option already at this level for combination. There is a recommendation of combination therapy or insulin therapy along with metformin or other oral agents if the blood sugar is this high. If the blood sugar is less than 9% A1C or an FBS less than 200, then monotherapy for most, and an option for combination therapy for some. The basis for the FBS of 200 is this graph of the relationship of the A1C to the average whole blood glucose, where if the average glucose is around 210, that corresponds to an A1C of 9. And therefore, if your FBS is 200 and above, your average glucose is probably whereabouts of this number, and therefore it's probably 9 or above. In the Diabetes Canada, their cutoff is not 9, it's 8.5. So when the A1C is 8.5 or above, the recommendation is to start start metformin immediately and consider combination therapy. Now, again, if they're very symptomatic or there is metabolic decompensation, then insulin can be initiated along with metformin. Here in Diabetes Canada and also in the American approach, ADA-EASD, whenever there's clinical CVD, then there are other options for therapy to be combined with metformin. In the ADA, again, if the A1C level is 1.5 to 2% above target. So again, our general target is around 7 less than 7%. So if your baseline A1C is 1.5 to 2% above 7, then there is already a recommendation for initial combination therapy. And if still higher, an A1C of 10% or above, or glucose levels of 300 and above, or a consideration of type 1 diabetes, then consider insulin as the first injectable. Now, again, the A1C target is less than 7% for most adults with type 1 or type 2 diabetes. You can consider a lower target in order to reduce the risk of CKD and retinopathy if the patient is young or is at low risk of hypoglycemia. But for the elderly, especially the functionally dependent, then A1C levels that are higher, like 7.1 to 8%, are already acceptable, and even much higher, up to 8.5, if they have recurrent hypoglycemia, if they have limited life expectancy, and even among the frail elders. And also from the Diabetes Canada, avoid higher A1C even among this age group in order to minimize the risk of symptomatic hyperglycemia and acute and chronic complications. For those who are already at the end of life, A1C measurements are not really recommended, and you just want to avoid symptomatic hyperglycemia and any hypoglycemia. So again, the general target is an A1C of less than 7%. And this target is modified by the presence of the following patient or disease features. If the patient is at risk of potential hypoglycemia or other adverse drug events, then you can aim for a higher target. For longer disease duration, short life expectancy, and the presence of important comorbidities and established vascular complications, then you can be less stringent. And of course, patient preferences, the patient doesn't like to put in a lot of effort, or resource and support systems are poor, then you can actually aim for higher targets. Metformin is still the first line for monotherapy and as the base drug for combination therapy. It's the most effective, has low risk for hypoglycemia, robust safety, and in the long term, it did demonstrate some cardiovascular benefits. And it's suitable for most persons with type 2 diabetes, including the CKD. And you can continue to use it if you have a stable eGFR more than 30, but it should not be initiated in patients with a starting eGFR of less than 45. And we all know how cheap metformin is. Now, after metformin, aside from glycemic control, the other consideration of whether you start combination therapy is the absence or presence of ASCVD. And if it is therefore present, then there is a decision to start drugs that are known to reduce MACE or major adverse cardiac events, cardiovascular events, such as the SGLT2 inhibitors or the GLP-1 receptor agonists. In the latest ADA 2021 guidelines, they actually say that if there is high risk or established ASCVD, CKD, or heart failure, then these are the treatment considerations. GLP-1 receptor agonists or SGLT2 inhibitors. If the patient is ASCVD or there are indicators of high risk for ASCVD, then you can choose either the injectable GLP-1 receptor agonist or an SGLT2 inhibitor with proven CV benefit. If, on the other hand, it's heart failure that's predominant, especially heart failure with reduced ejection fraction with an LV ejection fraction of less than 45, then SGLT2s are the preferred drugs. And in CKD, in diabetic kidney disease with albuminuria, preferably SGLT2 inhibitor or the alternative of a GLP-1 receptor agonist. So again, GLP-1 receptor agonists or SGLT2 inhibitors for those who are high risk. Now, in a guideline that we also published recently among the treating high risk, high CV risk persons with type 2 diabetes, we said that if either has been given and the target blood sugar has not been reached, a combination of these two agents may also be considered. And for patients without established ASCVD, the initial drug of choice is still metformin. And the choice of what to combine with metformin or when metformin is contraindicated or not tolerated depends on patient circumstances. So again, if there is ASCVD, then it's SGLT2 or GLP-1 receptor agonist, heart failure, CKD. But if there is none, then you can choose from among the different drug classes. So if the patient preference is to minimize weight gain or promote weight loss, what do you combine with metformin? You combine, again, the same drugs that are to be given for ASCVD. That's the GLP-1 receptor agonist or the gliflozin. If you want to minimize hypoglycemia, then choose any of the 4 Gs, no? The gliptins or the DPP-4 inhibitors, the GLP-1 receptor agonists, the gliflozins, such as the SGLT2 inhibitors, and the glitazones or the TZDs, so the 4 Gs. And if you want cost is the major consideration, then choose the older drugs such as the SUs, the TCDs, and even human insulin. So we've come to this point. If you have ASCVD, SGLT2 inhibitors, or GLP-1 receptor agonists, and if there's none, then consider weight loss, cost, or avoidance of hypoglycemia. Now, injectables, again, are preferred, especially insulin, for high A1C, especially with catabolic changes. In the Philippines, we said if it's more than 9, but internationally, in the American Diabetes Association, they said 10% or above, or plasma glucose of 300 and above. These are the considerations. If you want CV benefits, then prefer the GLP-1 receptor agonist, but it's costly. But if you want something that's very efficacious, cardiovascular outcome trials are neutral. However, the downside is hypoglycemia, then choose insulin. I'm coming to the last part of the lecture on complications. We all know that diabetes is the #1 cause of end-stage renal disease leading to dialysis. It's the #1 cause of non-traumatic limb amputations, and it's the #1 cause of adult blindness after cataracts and glaucoma. For ESRD, beginning sometime in 2002, 2003, diabetes exceeded GN and hypertension as the cause of ESRD. And in terms of screening, DM retinopathy, nephropathy, and diabetic neuropathy, at the time of diagnosis of type 2 diabetes, then screening is recommended for all of these microvascular complications. And how to then intervene to prevent these complications? Good glycemic control, BP and lipid control to prevent diabetic retinopathy. Aspirin is probably safe among those with diabetic retinopathy. And for diabetic neuropathy, again, glycemic control and lipid management, and avoidance of foot ulcers and wounds through foot care, protection, and certain medications can be given, especially for painful diabetic neuropathy. Screening for diabetic retinopathy is an initial dilated and comprehensive eye examination done by an ophthalmologist, and telemedicine programs that use validated retinal fundus photography with remote reading can also be done. So while it's not readily available in the Philippines, there are now moves to make this available. And when screening is done at the time of diagnosis and retinopathy is found among persons with type 2 diabetes, then yearly screening or follow-up is recommended. And if retinopathy is absent, then every 2 years. Treatment, if there is retinopathy, will involve laser photocoagulation among those with high-risk proliferative diabetic retinopathy, clinically significant macular edema, and in some cases of severe non-proliferative diabetic retinopathy. We also now have available intravitreal injections of anti-VEGF to reduce the risk of vision loss. And for primary and secondary prevention, you can actually give fenofibrate. For diabetic neuropathy, the most common form is distal symmetric polyneuropathy. And the recommended screening is, aside from careful history, it's actually temperature and pinprick sensation, even vibration sensation, and an annual 10-gram monofilament testing to assess the feet for risk of ulceration and amputation. We rarely need referrals to neurologists or even electrophysiologic testing. And when found to have diabetic retinopathy, you can give symptomatic relief, you can give topicals, or you can give drugs that try to influence the natural history of diabetic neuropathy. And for those of us who do manage painful diabetic polyneuropathy, there are three main options: the anticonvulsants, pregabalin and gabapentin, the SNRIs, duloxetine and venlafaxine, and the tricyclic antidepressants like nortriptyline. So please just take a picture of this table that shows you the doses, because most of us do start quite low, but the effective doses are actually quite high. So in the last 15 to 20 minutes, I talked about the following: tests, treatment, and prevention and management of complications. So I hope to be able to speak with you during the Q&A. Thank you very much. And I'd also like to thank Dr. Bien Matawaran for lending me some of his slides for this lecture. Thank you very much and good afternoon.
Thank you, Dr. Jimeno. Now proceed to our second lecture, our third focus session, and the open forum will follow shortly afterwards. Our next speaker for this session is Dr. Coralie Therese Di Macali. Dr. Di Macali finished both her residency in internal medicine and her fellowship in nephrology in Philippine General Hospital. Di Macali is the current co-chair of the UP Manila Training and Coordination Committee. She is also the Associate Dean for Academic Development and Associate Professor for the UP College of Medicine. I will now give the virtual floor to Dr. Di Macali, who discusses about chronic kidney disease and diabetes mellitus.
Good evening. I would like to thank the organizers of this grand scientific symposium for inviting me to speak before you today. So these are my disclosures. As seen from the data from WHO, the number of people with diabetes rose from 108 million in 1980 to 422 million in 2014. That's a fourfold increase over 34 years. And the prevalence of DM has been rising more rapidly in low and middle income countries than in high income countries. And between 2000 and 2016, there was a 5% increase in premature mortality from diabetes. Dr. Jimeno has told us that the prevalence of DM in the Philippines is about 8.2%. We all know that diabetes is a major cause of blindness, kidney failure, heart attacks, stroke, and lower limb amputation. So the global prevalence of CKD is about 10.4% in men and 11.1% in women. And one of the most vulnerable populations is the elderly. So that between ages 65 to 74, 1 out of every 5 men and 1 out of every 4 women will have CKD. And as this population ages, by the time they reach 75 years old, 5 out of the 10 elderly patients over 75 will have CKD. So these are data from our Philippine Renal Disease Registry from 2001 to 2015. And this graph just shows you an increasing incidence in orange over here and an increasing prevalence of diabetes of patients with CKD requiring dialysis. CKD constitutes a major cost burden to healthcare systems worldwide, and the Philippines is no exception. So our PhilHealth records show that in 2014, hemodialysis posted the most number of filed claims among procedures at close to 700,000, with total benefit payments amounting to close to 4.7 million pesos. And just 2 years later, what we see is the expenditure was more than 8 billion pesos, almost double. And this accounts for 22% of the PhilHealth allocation of 37.1 billion pesos. this poses definitely a great challenge to our resources. So as shown here in this slide, in data for 2015, diabetic nephropathy is now the most common cause of end-stage renal disease in the country, followed by hypertensive nephrosclerosis and chronic glomerulonephritis. This may be due to better control of diabetes in early disease, therefore we're seeing more complications. So diabetic kidney disease occurs in 20 to 40% of all diabetic patients. So how do we define CKD? So it is decreased in GFR to less than 60 ml per minute and or the presence of markers of kidney damage. One or more of these markers, including albuminuria, urine sediment abnormalities such as casts, pathologic abnormalities detected by histology, structural abnormalities detected by imaging, for example, pelvocalyectasia by ultrasound, a history of kidney transplantation, and electrolyte or other abnormalities that are due to tubular disorders. All of these findings should be found in at least 3 months for us to classify these patients as having chronic kidney disease. So what you see here is a conceptual model of CKD. So even before patients get to CKD, everyone should be screened for CKD risk factors. And if risk factors are identified, we try to mitigate these risk factors. And patients with risk factors for CKD should start to be screened for CKD. Once you reach the stage of damage, this is really the point of no return. But what you can do here is diagnose and treat comorbid conditions. And this is where we start giving therapies to slow down disease progression. After the stage of damage, we now see biologically an increase in creatinine, redounding to a reduction in GFR. And these patients will develop complications during this time. And we need to start priming them for renal replacement therapy so that when they develop kidney failure, the transition is smooth and we don't have to spend so much on emergency room admissions. So here is the time course of development of diabetic nephropathy, but it is classically found in patients with type 1 diabetic disease. Okay, so this begins with hyperfiltration. So GFR increases from 120 to about 150, characterized by histopathology, thickening of the glomerular basement membrane, and mesangial expansion. 10 years later, we start developing microalbuminuria. This cannot be seen on a dipstick analysis. So what you need to do is to submit a special test for microalbuminuria. Then about 5 to 10 years later, the patient develops macroalbuminuria. By then, the patient will be having edema, and progressively, he will be developing hypertension. And progressively, there will be a reduction in GFR or an increase in serum creatinine, accompanied by increase in phosphorus, increase in potassium, and the development of the anemia of CKD. And another couple of years later, you will develop end-stage renal disease. The course for type 2 diabetic patients may be actually shorter because oftentimes when we see them, we see them kind of late already in the disease when they already have microalbuminuria or some of them already with macroalbuminuria. So diabetes can be treated and its consequences avoided or delayed with diet, physical activity, medications, and a regular screening and treatment for complications. So preventive measures for the development of CKD basically include an early recognition and treatment of diabetes itself. So I have opted to base the rest of my lecture on the recent Kidney Disease Improving Global Outcomes, that's KDIGO, clinical practice guidelines on diabetes management in patients with CKD, just published last year. So here is the website posted on the slide. So the outline of this CPGs included 5 chapters on comprehensive care, glycemic monitoring and targets, lifestyle interventions, anti-hyperglycemic therapies, and the approaches to the management of patients with diabetes and CKD. So patients with diabetes and chronic kidney disease should be treated with a comprehensive strategy to reduce the risks of kidney disease progression and cardiovascular disease. So comprehensive care includes exercise, nutrition, smoking cessation, including glycemic and blood pressure control and the control of dyslipidemias, the use of SGLT2 inhibitors, RAS blockade, and the use of antiplatelet therapy such as aspirin for the prevention, both primary and secondary, of cardiovascular disease and stroke. So comprehensive care includes the use of angiotensin converting enzyme inhibitors, that's ACE inhibitors, or an angiotensin 2 receptor blocker, an ARB, for all patients with diabetes, hypertension, with or without albuminuria. So even without albuminuria, the ACE inhibitor or ARB are required for the reduction of albuminuria is achieved with the use of these agents. And I will talk about how we monitor these patients in terms of watching out for the complications of worsening GFR and hyperkalemia and even hypotension. So we recommend that the treatment of ACE inhibitors and ARBs be initiated in patients with diabetes, hypertension, and albuminuria, and they should be titrated to the highest approved dose that is tolerated. But again, we need to monitor, and we monitor for hyperkalemia and worsening azotemia. We can only use one RAS blocker at any one time. You may use mineralocorticoid receptor antagonists for the management of refractory hypertension, but they can cause hyperkalemia or a reversible decline in GFR. So here is an algorithm for the use of the ACE inhibitor. So we monitor within 2 to 4 weeks of initiating treatment. If your patient is normokalemic or you have a less than 30% increase in creatinine, you can increase the dose, or you can continue on maximally tolerated doses. If, however, your patient develops hyperkalemia or a more than 30% increase in serum creatinine, you must either reduce the dose of ACE inhibitors or ARBs or discontinue them as a last resort. If your patient is hyperkalemic, you need to look for other possible causes of hyperkalemia, and you can treat them with the use of potassium-losing diuretics such as furosemide, the use of sodium bicarbonate, especially if your patient has RTA type 4 because of the use of drugs, and cation exchangers. If, on the other hand, your patient has an increase in creatinine above 30%, try to look for causes of AKI, such as inadvertent volume depletion, or the use of drugs that can be potentially nephrotoxic, such as NSAIDs. Of course, you might want to consider renal artery stenosis, especially if your patients develop a flash pulmonary edema. So these are some of the drugs that can cause hyperkalemia, classified here according to how they indeed cause hyperkalemia. So you have NSAIDs, beta blockers, cyclosporin, and tacrolimus, that are calcineurin inhibitors that impair the release of renin. You also have heparin and ketoconazole that impair aldosterone secretion. And you have the use of sodium channel blockers such as amiloride and triamterene, or the use of the drug cotrimoxazole, which contains trimethoprim. And you have the use of aldosterone receptor blockers, as I mentioned earlier, such as spironolactone. So comprehensive care also includes the cessation of smoking, and physicians should counsel patients with diabetes and CKD to also reduce secondhand smoke exposure. Okay, now let's go to glycemic monitoring and targets. So we recommend target hemoglobin A1C to monitor glycemic control in patients with diabetes and CKD. So notice in this table that the reliability of HbA1c is high in early stages of CKD, but in the late stages of CKD, including dialysis and kidney transplantation, the reliability of HbA1c may be low. And in these cases, it is probably more useful to use continuous glucose monitoring. The target HbA1c ranges from 6.5 to 8% in these patients with diabetes and CKD not yet treated with dialysis. And notice that we become more liberal in the presence of these other conditions. So later stages of CKD, well, because in later stages of CKD, you have a marked reduction in insulin excretion, and this may aggravate hypoglycemia, especially if your patient is taking a lot of anti-hyperglycemic medications. The presence of severe macrovascular complications and many comorbidities, a short life expectancy, or impaired hypoglycemia awareness or unavailability of hypoglycemia management, or a condition that has a high propensity for the development of hypoglycemia. Okay, so now we go to lifestyle interventions. So for lifestyle interventions, the very first thing that we can do is really to control the diet of our patients. So patients with diabetes and CKD should consume an individualized diet that is high in vegetables, fruits, whole grains, fiber, legumes, plant-based proteins, unsaturated fats and nuts, but lower in processed meats, refined carbohydrates, and sweetened beverages. So we suggest maintaining a protein intake of 0.6 to 0.8 grams of protein per kilogram body weight per day for these patients with diabetes and CKD not yet on dialysis. Once the patient is on dialysis, we should not forget to increase dietary protein to as high as 1 to 1.2 to 1.3 grams per kilogram body weight per day for both peritoneal dialysis and hemodialysis. So here is a diabetic kidney disease food pyramid showing the recommended energy intake of 30 to 35 kilocalories per kilogram body weight per day, carbohydrate intake that consists of whole grains, fiber, fruit, and vegetables with minimal refined sugars, and sodium intake, here it says with less than 1.5 to 2.3 grams per day. For fat intake, more of unsaturated fats and reduction in saturated fats and trans fat. And we have here your protein intake. So what we see here is the Pinggang Pinoy. So half the plate with fruits and vegetables, but be wary about fruits that are high in potassium. And for 1/4 of the plate, you have carbohydrates. Again, also be wary about root crops such as potatoes, sweet potato, as they contain an increased amount of potassium. And the suggestion is to double boil the foods so that we can reduce the amount of potassium that you ingest. And then 1/4 here says protein. What you have to watch out for with increased dietary protein is the development of hyperphosphatemia. Dairy products and hard cheeses are also high in phosphorus, so they should be limited if your patient has significant hyperphosphatemia. Here is a summary of the dietary management in diabetic kidney disease according to various American associations and NKF, National Kidney Foundation, KDOQI group. So for proteins, We remind you again to modify dietary protein intake to increase it from 0.8 to 1.3 grams per kilogram body weight per day in patients already in end-stage renal disease receiving dialysis treatment. I will emphasize that we need to monitor potassium and phosphate levels. And what about for sodium? To limit the amount of sodium, one suggestion is to use non-processed fresh food, as processed foods tend to be rich in salt, and to utilize sodium-free herbs and spices. Be careful, however, of salt substitutes because they may contain potassium instead of sodium. But caution also is warranted because if you are seeing a patient with salt-losing nephropathies, sodium restriction will not be warranted for them. So maybe we should individualize the sodium restriction according to the conditions of the patient. So lifestyle interventions, aside from the dietary limitations we have, well, I will emphasize that sodium intake should be about 2 grams of sodium per day or 5 grams of sodium chloride per day as your maximum dose. We all know that a reduction in sodium intake can decrease systolic and diastolic blood pressure. It can decrease cardiovascular disease. It can decrease the risk of stroke. And some studies have shown a reduction in the progression of chronic kidney disease. So lifestyle interventions also includes moderate intensity physical activity for a cumulative duration of at least 150 minutes per week. So about maybe 30-minute exercises 5 times a week will do, to a level that is compatible with the patient's cardiovascular and physical tolerance. So what are some activities that are moderate intensity? So you have here brisk walking, biking, yoga, and swimming. So now let's go to anti-hyperglycemic therapies. So glycemic management, we said, should include already lifestyle and the first line treatment with metformin and SGLT2 inhibitors, plus additional drug therapy as needed for glycemic control, as seen in this slide. Okay, so the next few slides will focus on specific anti-hyperglycemic medications. So for metformin, we recommend treating patients with type 2 diabetes CKD and GFRs above 30 ml per minute with metformin. We need to monitor the GFR in patients treated with metformin and adjust the metformin dose when the GFR is less than 45 ml per minute, and avoid the drug or discontinue the drug once the GFR drops to less than 30 ml per minute. For patients who have been on prolonged metformin therapy, that is about more than 4 years on metformin, you need to monitor also for vitamin B12 deficiency. So this is the algorithm for that, no? And how do you know your patient is developing a vitamin B12 deficiency? Some of the findings are a peripheral neuropathy, such as the feeling of paresthesias. Sometimes your patients develop even vision loss and vision impairment and memory loss. So you might attribute this just to diabetes, but in fact, they are due to a vitamin B12 deficiency, which you can easily correct with vitamin supplements. So patients who have been receiving metformin at more than 1,500 milligrams per day are at risk. And they have been found that patients who are on vitamin supplementation do not develop the symptoms of vitamin B12 deficiency. So we also recommend treating patients with an SGLT2 inhibitor for GFRs above 30 ml per minute. And So if your patient is maintained on metformin and still has poor glycemic control, this is the next add-on drug. So these are the practice points for the use of these drugs. So choose an SGLT2 inhibitor that has documented kidney or cardiovascular benefits and take the eGFR into account. So during periods of fasting, surgery, or critical illness, it is best to avoid ketosis by withholding SGLT2 inhibitors. For patients at risk for hypovolemia, you have to decrease the diuretics before initiating treatment with these drugs. So the mechanism of action of these SGLT2 inhibitors is to induce glycosuria. And therefore, they will develop osmotic diuresis because of the high sugar in the urine. And this may cause hypotension and volume depletion if they don't replace that water. So reversible reductions in glomerular filtration rate may occur, but they're generally not an indication to discontinue therapy. Patients who have been transplanted cannot also use the SGLT2 at the moment because there are lacking studies in their use for KT patients. Now, if your glycemic control is not yet achieved with the use of metformin and SGLT2 inhibitors, or there are contraindications to the use of those drugs, the recommendation is to use a long-acting GLP-1 receptor agonist. Okay, and some of those drugs are listed over here. No dosage adjustment for liraglutide and lixisenatide, although in severe CKD data are limited. So exenatide CKD adjustment is to limit its use to patients with creatinine clearances above 30 ml per minute. So most of these are injectable preparations. So again, in the choice of your GLP-1 receptor agonist, you need to choose the drugs that have documented cardiovascular benefits. You start out with a low dose to minimize GI side effects. Do not use them together with a DPP-4 inhibitor. And it can be used with other medications. However, the combination of anti-hyperglycemic medications can induce more hypoglycemia. Okay, so finally, the last is the approach to management. So we recommend that a structured self-management educational program be implemented for the care of people with diabetes and CKD. And the goals of such a structured educational program are to improve diabetes-related knowledge, self-management, self-motivation, to improve vascular risk factors. And important is the engagement with medication, improve compliance, okay, to glucose monitoring and complication screening programs, to reduce the risk of diabetic-related complications, and importantly, to improve emotional and mental well-being, treatment satisfaction, and quality of life. So we also suggest a collaborative approach. Policymakers, institutional decision makers, team-based integrated care that is focused on risk evaluation and patient empowerment to provide comprehensive care in our patients with diabetes and CKD. So team-based integrated care supported by decision makers should be delivered not only by physicians, but together with non-physician personnel, such as trained nurses and dietitians, pharmacists, healthcare assistants, community health workers, and peer support groups, preferably with the knowledge of CKD. So we need to empower our patients so that they are partners in their management. And so we need to provide that coordinated care so that the patients are managed as a whole and not individually by each of the specialists that see our patients. So diabetes can be treated and its consequences avoided or delayed with diet. physical activity, medication, and regular screening and treatment for complications. So preventive measures for the development of CKD include an early recognition and treatment of diabetes itself. So my takeaways from this presentation include the following. So comprehensive care of the CKD diabetic includes lifestyle interventions such as moderate exercise, what did we say? 150 minutes per week, smoking cessation, together with pharmacologic management to control glucose, blood pressure, and dyslipidemia, as well as the use of renin-angiotensin system blockers in patients with diabetes, hypertension, with or without albuminuria. Second, a healthy diet that is high in vegetables, fruits, whole grain, nuts, legumes, and uses unsaturated fats, that is low in processed meats, refined carbohydrates, and sweetened beverages is recommended. So low salt in the hypertensives and low dietary protein intake, 0.6 to 0.8 grams per kilogram body weight in the non-dialytic CKD patient, increased to 1.2 to 1.3 grams per kilogram per day in patients already on dialysis. We need to, however, watch out for foods that are high in potassium and phosphorus. Third is glycemic monitoring with the use of glycosylated hemoglobin twice a year, up to 4 times a year when titrating the dose for patients with early CKD. Remember that the HbA1c may be unreliable already in patients with end-stage renal disease, in which case we might need to shift to glucose monitoring to recognize hypoglycemia in these patients with more severe forms of CKD. Our glycemic targets are also modest, 6.5 to 8%. And they should be individualized according to the CKD stage of the patient and the risk of hypoglycemia. Later stages of CKD and more risk for hypoglycemia will probably recommend a higher glycemic target of close to 8%. So to prevent the complications of hypoglycemia. Among the anti-hyperglycemic therapies that I have discussed, so most patients with GFRs above 30 ml per minute will benefit from treatment with metformin and SGLT2 inhibitors. We need to adjust the dose of metformin once the GFR is less than 45 ml per minute, discontinuing the drug when the GFR drops to less than 30 ml per minute. Prolonged use may cause vitamin B12 deficiency, and I forgot to also emphasize that metformin is discontinued at GFRs less than 30 ml per minute because they have a risk of inducing lactic acidosis, though I have not seen this in my practice. So for SGLT2 inhibitors, we suggest that you prioritize a drug that has documented cardiovascular benefits. With the use of SGLT2 inhibitors, you should watch out for volume depletion, hypotension, and ketosis. So the recommended add-on anti-hyperglycemic therapy is a GLP-1 receptor agonist, again with documented cardiovascular benefits, and do not combine DPP-4 inhibitors when you are using GLP-1 receptor agonists. And finally, we need to empower our patients by creating a structured self-management program that takes into consideration the local context, cultures, and the availability of resources. And we need to deliver a team-based, integrated, and comprehensive care that is supported by decision makers. So the key to individualized management, delivered by a collaborative team of healthcare workers, is via shared decision making. So thank you very much.
Thank you, Dr. Limakali.
We now proceed to the open forum, to be moderated by Dr. Iris Tiel Isiptan and Dr. Jacqueline Monville. Dr. Isiptan is a professor and chief of the Medical Informatics Unit of the UP College of Medicine and the chair of the UP Manila Telehealth Committee. Joining Dr. Isiptan in the discussion is Dr. Jacqueline Monville. Dr. Momvile is the current Provincial Health Officer 2 of Agusan del Sur and is at the heart of the region's COVID-19 response.
Wow. We went through quite a lot with the lectures with Dr. Jimeno and Dr. Dimacali. Thank you very much. Jackie, you have the first question.
Yes, no, actually the lecture was really good because it incorporated yung maraming context natin dito sa grassroots, no? So our first question goes to Dr. Cecilia Jimeno. Ma'am, the question is, in low resource settings such as the LGUs, no, in the provinces, what diagnostics can you recommend to detect the diabetes?
Okay. Well, ideally, really, we would like any of the standard tests, no? FBS, RBS, OGTT. I think most of the hospitals, clinics, diagnostic centers do have it. But we recognize also that there are areas in the country that even that wala. So in fact, the WHO did make some allowance for that in those settings, you may actually do capillary blood glucose as the diagnostic test of choice. But realize that the capillary test is typically, when you do it, it's a bit higher than the venous plasma, and therefore the WHO actually gives a lower cutoff. So for venous plasma, it's 7 and above for diabetes. For capillary, it's actually more than 6.1. That's around, mga ilan yun, Iris? 116, mga ganyan. Mas mababa. Pero, of course, it's not routine. And that's why we're writing the practice guidelines to make sure that these tests are available throughout the country, including the A1C.
Thank you, Ma'am Cecil.
Okay, so we have a question here for Dr. Dimacali. Ma'am, you mentioned earlier that in ESRD or CKD, there will be a point when the HbA1c will be unreliable. Is there a certain EGFR cutoff when we can begin to consider that we shouldn't be using the HbA1c?
Amir,
Yeah, sorry. Okay. So if you looked at the table, the recommendation was to use HbA1c early CKD. So up to CKD stage 3. Starting CKD stage 4, when the patients start developing metabolic acidosis, anemia, these are conditions that affect the reliability of the HbA1c. So I would recommend that up to stage 3, it will be fine. What is stage 3 defined as? GFR of less than 60 ml per minute. But once you reach stage 4, the definition of stage 4 is less than 30 ml per minute, between 15 to 30 ml per minute. So that's the recommendation for the use of HbA1c.
Okay.
Ma'am Iris, there's another question to Doc Cecilia Jimeno. Ma'am, if the patient is requiring insulin therapy, this is from a general practitioner, do we refer immediately to the specialist?
Okay, that's a really good question. The DOH actually, I think 3 or 4 years back, did make provisions, to have intermediate acting insulin, NPH insulin, as well as biphasic human insulin available throughout the country. So it's available actually for our indigent patients for free. Nagkagulo lang because of COVID, but it was available to many of our patients. And therefore, since many of the GPs and even some Gen IMs don't really know how to initiate insulin, we actually went around the country, the Philippine Society of Endocrinology, Diabetes and Metabolism, in collaboration with the DOH NCD program, did go around the country educating our GPs on initiating insulin. So we don't see any reason why GPs, Gen IMs, cannot initiate intermediate acting or basal insulin, especially the long-acting basal insulin analogs. Once patients will require probably 2 or more injections, let's say magbe-basal plus ka na or yung twice a day na biphasic, maybe that's the time that you may refer, especially if you're not comfortable comfortable already. And this is especially true when the insulin requirement is now approaching 0.5 units per kilo. Kasi usually yun na yung point na medyo mag-hypo na sila, they will require a second insulin dose. So yun yung mga key points. Pag magdadalawa ng injections or pag mataas na yung basal mo, yung total mo the whole day approaches 0.5 units per kilo, maybe it's time to refer to a specialist.
Yeah, this is really important, ma'am, no? Especially that we are gearing towards universal healthcare. So our primary care doctors must also learn to give insulin at an early stage.
Yes, and on that note nga, earlier Dr. Dimakali was talking about coordinated care. So perhaps we should also ask her, when should we refer a person with diabetes to a nephrologist?
Sana may poll para tanungin ko kayo.
Kailan ba kayo? Ko lang kasi yung nephro eh. Asawa ko kasi nephro. So,
kailan ka nagre-refer, di ba? Okay, so early nephrology referral has been shown to improve outcomes actually. So we don't want you to refer to us pag stage 5 na siya, magda-dialysis na siya. We want you to refer earlier when there's something that we can still do. And if you looked at my concept of, the concept table figure of CKD progression, diba? I said it's the stage of damage, no return. You're going to go 90% of that will go progress to further stages of CKD. So we want you to refer early. When I say early, maybe at the latest, pag stage 4 siya. So 30 ml per minute is my cutoff absolutely for referral. Don't worry, we will refer back to you and just tell you this is what you need to do and this is what you need to monitor for. Yes. It's just so that it's guided for the patient. Remember, kayo yung mag-manage holistically, di ba? Kayo yung magta-tie up ng care and treatment for the patient.
Yes.
It's not the specialist. That's the spirit of universal healthcare.
And in relation to that, Doc Dimakali, what diagnostic would you recommend to our primary care physicians to detect, aside dun sa pag-assess ng risk, no, to detect early CKD?
Okay, so what did we say definition of CKD was? A GFR of less than 60 ml per minute. Okay, before, with the Philippine Society of Nephrology, tried to partner with the laboratory group in DOH to see if they could convince all laboratories to report GFRs. Okay, why? Because if you just look at serum creatinine, a normal serum creatinine level is not always a normal GFR. Okay, but if you have a calculator, a QX calculator on your phones, okay, you can look for the nephrology portion and look at computation of eGFR. Okay, so the eGFR is estimated glomerular filtration rate. And you use the CKD epi formula. So maraming formulas kasi noon, no? So CKD epi formula has been validated by one of our colleagues in the Philippine Society of Nephrology to be the best formula to use for estimating GFR. Okay, so that's one. If you can get a creatinine that might be available in your center, that's one. The second is to look at the urine. Okay, what do we look for in the urine? Dati kasi uso, di ba? You monitor the urine when you're monitoring for hyperglycemia, di ba? Dati may mga strips na binibigay. So ngayon, ang problema natin, if your patient is on an SGLT2 inhibitor, talagang magpa-positive yung glucose sa urine, no? What we're going to look at now in the urinalysis will be albuminuria. Okay? But once your dipstick becomes positive for albuminuria, that's unfortunately quite late. That puts you in the stage of damage already. Okay? So in that case, you need to monitor more closely. So rather than following up the patient, for example, every three months or every 6 months, you will now follow up the patient more frequently because that's the time when baka biglang tumaas yung kanyang creatinine. So for me, the urine is a window to the kidney.
Thank you.
Okay, I'm looking at that time and apparently meron tayong isang pahabol na question from YouTube. Okay, from Silvestre Libertario. Can you comment on vitamin D deficiency in some patients with diabetes?
Vitamin B?
D.
D.
Yeah. Dog.
Dog. Well, there are actually some studies where if you have vitamin D deficiency, apparently there are some indications that it could cause insulin resistance, and that's why there was actually a strong move before to also give vitamin D supplementation. The other rationale in the Philippines why for many people vitamin D as a supplementation could be a good idea is because we do have a high prevalence of vitamin D deficiency. We did that. There was a study done in at least two urban areas in the Philippines, and despite asking all different kinds of people and testing them, even those people who are actually spending most of their time outdoors, medyo mataas yung vitamin D deficiency rates natin. It was more than 30%. So vitamin D supplementation is a good idea among persons with diabetes actually.
Well, even with patients with CKD, because you know that when you have a patient with CKD, you can't convert the inactive form of vitamin D to its active form. And so parang there's vitamin D deficiency. But caution lang, when you give vitamin D, you can increase calcium, but you can also increase phosphorus. So if you already have hyperphosphatemia, you might aggravate that hyperphosphatemia in CKD. But it's a good drug to start off to reduce the secondary hyperparathyroidism that occurs in patients with CKD.
Okay, I think that's all the time we have for you. And I can hear someone typing. I think it's Dr. Jimeno still answering the questions in our Q&A box. So I think they will be doing that even though we have to end the session already. Thank you very much, Dr. Jimeno and Dr. Dimacali.
Thank you, speakers and moderators. We would like to award the Certificate of Appreciation to Dr. Cecilia Jimeno for her invaluable contribution as the resource speaker on the standard of care in patients with diabetes mellitus during the UP College of Medicine Grand Scientific Symposium. This Certificate of Appreciation is given to Dr. Coralie Dimacali for her invaluable contribution as a resource speaker on chronic kidney disease in diabetes mellitus patients during the UP College of Medicine Grand Scientific Symposium.
We would also like to award the Certificate of Recognition to Dr. Iris Thiel Isiptan and Dr. Jacqueline Francis Monville for their contribution as moderators for the focus session on diabetes mellitus, given this 22nd day of September 2021.
Thank you also to the participants for joining us today. Your attendance is greatly appreciated. Ask our attendees to answer the evaluation form as part of your attendance. CPD units will be credited from your attendance. Please find the link on the chat box below. This ends the second day of our Grand Scientific Symposium 2021. We invite everyone to attend the conference tomorrow, as we still have more exciting topics to discuss, along with the lineup of esteemed speakers. Good evening, everyone, and see you tomorrow.